The topic of which we are going to cover MCQ is from what? Congenital lesion, anatomy and physiology of nose, right? Congenital lesion, anatomy, physiology of nose. The first question is commonest presentation of infant with bilateral choanal atresia, right? The right answer is difficulty in breathing. Choanal atresia is associated with what? Colobomatous blindness, heart disorders, ear disorder, cranial nerve lesion, right? Okay, these are what? These are the association of choanal atresia. So the right answer is A, B, D and E. Colobomatous blindness, heart disease, ear discharge, ear disorder, cranial nerve lesion. Here the renal anomaly is not the right answer. It is urogenital anomaly, not renal anomaly. 2-year-old child is brought to hospital with a compressible swelling at the roof of nose, right? Roof of nose. See the clinical picture. The most likely diagnosis is, what is the most likely diagnosis? Since it is present where, okay, now here, since it is present right here, right, it can be what? The most common diagnosis is, what is the most common diagnosis? It is meningoencephalocele, right? 2-year child with compressible swelling at the root of nose is likely meningoencephalocele, right? Now talking about this lacrimal sac cyst, it occurs as compressible swelling near the medial canthus, right? Okay, and talking about what? This ethmoid sinus cyst present as a swelling at medial quadrant of orbit, pushing orbit forward and laterally, right? Okay, true about nasal glioma, right? 60% are extranasal. CT provides the bony detail and MRI differentiate between glioma and nasal encephalocele. That is what? True about what? Nasal glioma. External nose is formed by, what? It is formed by our, how many? 3 paired and 1 unpaired cartilage, right? 3 paired and 1 unpaired cartilage, right? The osseo-cartilaginous junction on the dorsum of nose is osseo-cartilaginous junction, bone and cartilage junction on the dorsum of nose is, what is it? It is our rhinion, right? Rhinion is the osseo-cartilaginous junction. Okay, moving further, that is our nasal valve is formed by all accept. It is formed by nasal valve, right? It is formed by septum also. It is not formed by middle turbinate, right? It is formed by lower end of upper lateral cartilages, inferior turbinate, right? Not middle turbinate. Inferior turbinate, septum, lower end of upper lateral cartilage. Choana is what? Posterior near. Ethmoid bone forms all accept. Okay, ethmoid bone forms all accept superior turbinate, middle turbinate, inferior turbinate. No, inferior turbinate is separate bone. On-chain process is also the part of ethmoid bone. The inferior turbinate is, it is separate bone. Which of the following is known as fourth turbinate? Okay, the fourth turbinate is our supreme turbinate, right? Supreme turbinate. Turbinate that articulate with ethmoid is, what? Inferior turbinate. Not other, because superior, middle, these are itself a part of what? Ethmoid bone, right? So inferior turbinate articulates with ethmoid. All these structures are found in lateral nasal wall accept, right? Lateral nasal wall. Superior turbinate, it is found. Agar nasal, it is also found, right? Hasner's valve, it is also found. Vomer, it is not found, right? Vomer is independent separate bone which forms posterior inferior part of septum proper, such that medial wall of nose. It is not found on lateral wall, it is found in medial wall, right? The nasolacrimal duct opens into, it will open into what? Right? Inferior meatus. Nasolacrimal duct opens into inferior meatus, right? Okay. Now, okay, the direction of nasolacrimal duct is, what we are going to remember? We are going to remember date of birth, right? DOB, that is downward, outward. Outward means what? Lateral, right? And B, backward. Okay, that means the option number what? B is the right one. Downward, backward and lateral. Paranasal sinus opening into middle meatus is, okay, into middle meatus, anterior group of paranasal sinuses open, like maxillary sinus, anterior ethmoidal sinus, it is not posterior ethmoidal sinus. The frontal and sphenoid, yes, frontal sinus will what? Open, right? this will open. Okay, all drain into middle meatus except, right, middle meatus. Maxillary sinus, yes. Frontal sinus, yes. Ethmoidal sinus, yes, but not nasolacrimal duct because it drain into inferior meatus. Frontonasal duct open into frontonasal duct, right? Here it is talking about what? Okay, the frontonasal duct opens into, it will open into middle meatus, right? Middle meatus. Now moving further, the frontal sinus drain into, we already talked about it, that is middle meatus. The maxillary sinus open into middle meatus 8. Maxillary sinus open into middle meatus 8, it will open into what? 8 infundibulum, right? The hiatus similaris is present in, where is hiatus similaris is present? Now it is present in middle meatus, right? Below bulla ethmoidalis is seen in, now where is bulla ethmoidalis seen, right? It is also seen in middle meatus, bulla ethmoidalis and hiatus similaris. Osteometal complex connects, what it will connect? Osteometal complex, it will connect what? Nasal cavity with maxillary sinus, right? The opening of posterior ethmoidal sinus is anterior, we said that is middle meatus, right? Now what is the posterior ethmoidal sinus? Opening of posterior ethmoidal sinus, that is our, right, what is it? It is superior meatus, right? Posterior ethmoidal sinus is superior meatus. Sphenoidal sinus, now what about the sphenoidal sinus, which is also not opening into middle meatus, right? The opening of sphenoidal sinus is sphenoethmoidal recess, right? Sphenoethmoidal recess. The sphenoidal sinus open into sphenoethmoidal recess just above superior turbinate, right? Superior turbinate. Okay, which of the following bone do not contribute to nasal septum? Okay, right, nasal septum, that is our lacrimal bone, right? Lacrimal bone is exclusive to what? Lateral wall. Similarly, vomer is exclusive to medial wall, right? Okay, the shape of septal cartilage is, what is the shape of septal cartilage? Quadrangular. The quadrangular cartilage is attached to all of the following except, it is attached to all of the following except sphenoid, right? It is posterior mostly present. The nasal septum, right? The nasal septum is supplied by, it is mainly supplied by what? It is mainly supplied by our mainly external carotid artery, right? It is mainly supplied by external carotid artery, right? Okay, the artery which do not contribute to Little's area, okay, the artery which do not contribute to Little's area is our what? Posterior ethmoidal artery. Other all sphenopalatine artery, right? Our anterior ethmoidal artery, superior labial branch of facial artery, these all contribute to Little's area, right? Now anterior ethmoidal artery arise from anterior ethmoidal artery. Okay, anterior ethmoidal artery, it arises from, where it arises from? It arises from ophthalmic artery, right? It arises from ophthalmic artery. Ophthalmic artery, there are two branches, anterior ethmoidal and posterior ethmoidal. Posterior ethmoidal do not contribute to Little's area, anterior ethmoidal only does. The first paranasal sinus to develop at birth is, we need to remember, MESF, right? The first paranasal sinus to develop at birth is, what is the first paranasal sinus, right? That is our maxillary sinus, right? Okay, the sinus not present at birth is, okay, sinus not present at birth is, that is frontal sinus, that is the most late sinus, or that will attain its maturity as it was at puberty. The least common sinusitis is, what is the least common sinusitis? Okay, that is our sphenoid sinusitis. The true about sphenoid sinus is lined by stratified squamous epithelium, right? Okay, is it lined by stratified squamous epithelium? No, right? Duct open into middle meatus, that's also not right. Open into sphenoethmoidal recess, right? Present at birth, that's right. Present in greater wing of sphenoid, not right. So the C and D are the right statement. The which sinus is not present? Which sinus is not the part of paranasal sinus? Frontal, it is. Sphenoid, ethmoidal, piriform is not the part. The most superior sinus in the face is, what is the most superior sinus in the face? Okay, we know that is frontal sinus, right? The anterior fistula is most common after extraction of, and antral fistula is most common after extraction of which one? That is first molar, right? First molar, antral fistula, right? A and the first, right? Opening of maxillary sinus is at the first molar and second premolar, that is also important. The opening of maxillary sinus is at what? At the what? Is at first molar and second molar, right? Second premolar. The maxillary sinus achieves maximum size at it achieves maximum size where? It achieves maximum size at secondary dentation, right? It achieves maximum size at secondary dentation. Okay, Odini cell and Haller cells are seen in relation to Odini cell, O for optic nerve, right? ON for optic nerve. So optic nerve is right answer, and Haller cells are for floor of orbit, right? So the option number A is the right answer. The pain sensation from ethmoidal sinuses are carried by what? Okay, these are carried by nasociliary nerve, right? These are carried by nasociliary nerve. Ethmoidal sinus. The ciliary movement rate of nasal mucosa is, what is the ciliary mucosal movement rate of nasal mucosa? These are 5 to 10 mm per minute. These are what? 5 to 10 mm per minute. Okay. The further question, the function of mucociliary action of upper respiratory tract is, what is the function? Okay, temperature regulation, is that the function? Okay, let's go other. Increased velocity of inspired air traps the pathogenic organism in inspired air. That is the most important function of upper respiratory tract. The movement of mucus in air is by, okay, the movement of mucus in air is by what? It is by mucociliary action, right? Mucociliary action. During inspiration, the main current of airflow in normal nasal cavity is through what is the where the main current of air flows in nasal cavity? In middle part of cavity in parabolic what manner, right? In middle part of cavity in parabolic curve, the main current of airflow, right? Airflow of nose is in parabolic curve, both during inspiration and expiration, right? The odor receptor is present in, right? Odor receptor is present in, they are present where? In olfactory epithelium, right? Olfactory epithelium. Anosmia is common, and it is common in coryza also, atrophic rhinitis also, fracture of cribriform plate also. So these are the right answer, right? In coryza also, right? In atrophic rhinitis also, in fracture cribriform plate also. Parosmia is what? The perversion of smell sensation. Parosmia means the perversion of smell sensation, right? Is what? Here the good smell appears bad, right, to the patient, right? Okay, perversion. Which of the following syndrome is associated with anosmia, right? The syndrome that is associated with anosmia is our Coleman's syndrome. Coleman's syndrome, right? The nasal cycle is cyclic alternate nasal blockage occurring how many, right? Cyclic alternate nasal blockage occurring every what? Every 5/2 to 4 hours, right? That is 2.5 to 4 hours, right? Okay, that is what? That is our the nasal cycle, right? The cyclical alteration of nasal blockage. All are true about nasolabial cyst except, right? All are true about nasolabial cyst except, right? Arise from adenoid epithelium. No, that is not the right answer, right? Present with swelling in anterior nasal floor. That is right answer. Unilateral, that's right, usually seen in adults. So the right answer is A. Thoricum speculum is used to visualize. We know thoricum, right? Vana and thoricum, they are used to visualize anterior nasal cavity, right? Okay, so the right answer is anterior nasal cavity, which is not visualized on posterior rhinoscopy, right? On posterior rhinoscopy, which is not visualized, that is our our structure that is not visualized is our superior concha, right? Superior concha is only seen at the time of what? Nasal endoscopy, right? Nasal endoscopy. The pneumatization pattern of sphenoid sinus are all except precellular concha, postcellular and conchal, right? Concha bullosa and conchal. So here it is concha bullosa is not what? The pneumatization pattern, right? These are what? The pneumatization pattern of the concha bullosa is a pneumatization pattern of what? Middle turbinate, right? Now here are all precellular, right? Postcellular, conchal, these are the pneumatization pattern of sphenoid. What percent of total airflow through nose passes through olfactory region? That is what? 5 to 10% only through olfactory region. Boundary of anterior nasal nerve are all except, right? Inferior turbinate, it is middle turbinate, no it is not, right? So the middle turbinate is the right answer. Lining of maxillary sinus is, what is the lining, right? These are what? Keratinizing or non-keratinizing? These are obviously what? These are these are not squamous epithelium, these are ciliated columnar, right? These are ciliated columnar. Sphenopalatine foramen is located at the end of which turbinate? Sphenopalatine foramen is located at the end of which turbinate? That is our middle turbinate, right? Middle turbinate, sphenopalatine foramen. The narrowest part of nasal cycle is, that is our nasal valve, right? Ethmoidal bulla is seen in where? Infundibulum, bulla, where these are seen? Middle meatus. Infundibulum lies in between. Where does it lies? It lies in between our what? Okay, lateral wall and uncinate process of what? Ethmoid. It lies in between what? Lateral wall and uncinate process of ethmoid. This is the region of where infundibulum lies, right? The Onidi cell refer to, what are Onidi cells? Refer to what? These are the posterior, right? These are the posterior group of ethmoidal cell which are in relation to what? Optic nerve, right? Posterior group of ethmoidal cells. The cause of choanal atresia is bucco-nasal membrane, persistent bucco-nasal membrane. The ventilation of sinus occurs during expiration, right? Ventilation occurs during expiration. Which turbinate is seen only in nasal endoscopy? We already said it, that is superior. Halar cells are present in, where are the halar cells present? We already said it, that is our roof of maxillary sinus. Roof of maxillary sinus or orbital floor, same thing, orbital floor. Lining of maxillary sinus is, we already said, ciliated columnar, right? The Onidi cell is in relation to, we already said, where? The Onidi cells are present, where these are present? These are present in relation to sphenoid sinus, right? Posterior group, that's why relation to sphenoid sinus. A child is normal while crying but develops cyanosis on breathlessness when being quiet. The most probability diagnosis is, that is choanal atresia, right? Sphenoethmoidal recess has opening of sphenoethmoidal recess, we know that is sphenoid sinus, right? Which sinus is last sinus to appear radiologically on X-ray? What is the last sinus to appear radiologically? Last, that is frontal sinus, last to develop. The valve of Heisner is what? That is the opener of nasolacrimal duct. Hiatus semilaris is present in, where it is present? It is present, hiatus semilaris is present in middle meatus, right? We know about it. The eustachian tube is located in, where it is eustachian tube is located? It is located posterior to what? Inferior turbinate, right? Inferior turbinate. Similarly, all of the following are true regarding maxillary sinus except, right? True regarding maxillary sinus except largest present sinus, yes. Commonest sinus involved in acute bacterial sinusitis, that is also right. Brain refer to lower premolar and molar teeth via trigeminal nerve. No, these are upper first molar and second molar. So, right, this is the not right answer, right? In maxillary sinusitis, pain is referred to what? Upper teeth, not to lower teeth, right? Open into middle meatus, that's right. So the answer is option number C. Rhinomanometry is the measurement of, it is the measurement of nasal air flow and nasal air resistance. The Vidian nerve is what? The Vidian nerve is nerve of pterygoid canal, right? Nerve of pterygoid canal. Roof of nasal cavity is formed by all except, it is formed by all except, it is not formed by palatine process of maxilla. It is formed by sphenoid, cribriform plate and frontal process also, but palatine process of maxilla, it is what? It is the bone of what? Lateral wall, right? Osteometal complex consists of the following except osteometal. Sphenoidal sinus opening, no. Frontal sinus opening, yes. Anterior sinus opening, yes. Maxillary sinus opening, yes. So the right answer is sphenoidal sinus opening. Right now, where does the given sinus drain into? Now the sinus, right? Here it is talking about maxillary sinus, right? Now obviously the sinus drain into what? It will drain, okay, where does the sinus, it is asking about, right? Okay, given sinus drain, it is asking about maxillary sinus only. It drains into what? Infundibulum, right? Infundibulum, that will eventually goes into middle meatus. The shaded area represent, it is the shaded area represent what? Obviously it represents what? Osteomeatal complex, right? Osteomeatal complex. Now further, the shaded area sky blue is lined by which epithelium? Now here it is talking about this, it is lined by which epithelium? That is olfactory epithelium, right? That is lined by, okay, olfactory epithelium, right? Okay, moving for the next question. The encircled area on the lateral wall of nose is a picture of, now here this is the picture of sphenopalatine foramen, right? It is a picture of sphenopalatine foramen. The marked structure on X-ray is, what is the marked structure right here? Now here the marked structure, what is the marked structure right here? It is sphenoid sinus, right? What is it? It is sphenoid sinus. Which paranasal sinus is last to completely develop? We already know. That is what? That is our frontal. Nerve not involved in olfaction while eating is, right? While eating, which is the nerve that is not involved in olfaction? That is hypoglossal nerve, right? It is pure motor nerve. So these are all about the MCQs from what? Our chapter congenital lesion, anatomy and physiology of nose, along with paranasal sinuses also. Now here we are going to talk about the MCQ from the disease of external nose, right? Disease of external nose. Now without delay, let's move into the MCQ. The first MCQ is rhinophyma is associated with. Now it is associated with what? Hypertrophy of sebaceous gland. The true about rhinophyma is, right, it is what? It is associated with acne rosacea, right? Depressed breeze of nose may be due to any of the following except depressed nose. It can be because of any of the reason except what? Except our acromegaly, because leprosy, syphilis, septal abscess, all these causes depressed breeze of nose. True about rhinophyma is, it is what? True about rhinophyma is, okay, pre-malignant? No, it is not pre-malignant. Mostly commonly due to diabetes mellitus? No. More common in alcoholic? No. Hypertrophy of holocrine gland? Okay, that is the true statement about rhinophyma, right? Rhinophyma occur due to hypertrophy of sebaceous gland, right? Sebaceous gland, which is what? Which is the what? Holocrine gland. That means entire cell disintegrate while discharging its secretion. The crook nose is due to, what? It is the crook nose is deviated dorsum but tip remains in midline, like this, right? Crook nose, right? Remain in midline. The rodent ulcer is, what is the rodent ulcer? This is basal cell carcinoma. The following are true regarding the disease shown in the following picture except. So here it is, what is what? It is what? It is the picture of rhino, what? It is the what? Picture of rhinophyma only, and here it is considered to be the end stage sequelae of acne rosacea, right? It is the right statement. It is also called known as potato tumor and rum whiskey nose. It is right. Hypertrophy of sebaceous gland, right. Treatment is surgical excision of excessive sebaceous tissue and underlying nasal cartilage. Treatment is surgical excision of excessive sebaceous tissue. No, it is not right, right? It is the not right statement, right? Okay, now talking about the following is the following nose deformity should be treated by. Now here you can say, what is this? This is what? This is saddle nose deformity, right? Saddle nose. Now here, now what we can do is we can do augmentation rhinoplasty, right? So answer is augmentation rhinoplasty. These were all about the MCQ from external nose, what? Diseases. Now we are going to cover the MCQ from disease of nasal septum. Now the percentage of newborn with deviated nasal septum is, it is around 60%, right? So high. The feature associated with DNS include all of the following except epistasis. It is associated. Atrophy of turbinate, no, right? There is no atrophy of turbinate, so this must be the answer. Hypertrophy of turbinate, right? Yes, there can be hypertrophy of turbinate, right? Okay, okay, and another is recurrent sinusitis. Yes, the atrophy of turbinate will not occur. DNS may be associated with all of the following except recurrent sphenoiditis, right? It is not associated with recurrent sphenoiditis, right? Acute otitis media, yes, it may be, right? Hypertrophy of inferior turbinate, yes. Recurrent maxillary sinusitis, yes. So the answer is recurrent sphenoiditis. The etiology of anterior ethmoidal neuralgia is anterior ethmoidal neuralgia. The etiology is middle turbinate passing on nasal septum, right? Pressing on nasal septum. Middle turbinate, right? Pressing on nasal septum. For DNS surgery, what is required? DNS surgery can be done in septal spur with epistasis, yes. Septal deviation, no, it is not required, right? It should be what? It should be symptomatic. Nasal obstruction, yes. Recurrent sinusitis, yes. Prolonged DNS, no, it should be symptomatic. So the option number A, C and D are right. Cottle test is for patency of near in. It is used in where deviated nasal septum. Cottle test. Improvement in nasal patency by retraction of lateral part of cheek and thus testing the valvular component of noses. It is Cottle's test, right? Here Cottle test is what? Simply improvement. Cottle test is what? Improvement in nasal patency by retraction of lateral part of cheek and thus testing the valvular component of the nose, right? All of the following are true of septoplasty operation for DNSSF indicated in septal deviation. Okay, now here yes, it is mucoperichondrium removed. It is removed, right? Preferably done after 17 years of age. No, it can be done earlier also, right? Okay, and done in case of epistasis. Yes, it can be. So the answer is option number C, right? Next question: which of the following surgery is not contraindicated below 10 years of age? That is what? That is septoplasty and face both, but here we choose face, right? Face is more appropriate. Alternate for SMR is, that is our septoplasty, right? We know the alternate for SMR is what? Our septoplasty, right? Similarly, the common indication of septoplasty is DNS with symptom. That's right. Anosmia, no. Slaughter neuralgia, yes, it is. Septal spur, it is. So A, C, and D are the answer. Killian incision is used for SMR operation. Similarly, phrase incision is used for what? That is used for septoplasty. Local anesthetics used for nasal surgery. What is the local anesthetic used? These are both, that is cocaine paste and xylocaine, both. True about septal hematoma is occurs due to trauma. That's right. Can lead to saddle nose deformity. That's also right. Conservative treatment, no, that's not right. May lead to abscess formation, right. Surgical drainage has to be done immediately, right. So answer is A, B, D, and A. After laparoscopic appendectomy, patient has fallen from bed on her nose, after which she had swelling in nose, difficulty in breathing. The next step in management is what we need to do. What we need to do is we need to what? We need to surgically drain, right? Surgically drainage of the hematoma, septal hematoma, right? Because there might be what? Probable septal hematoma which is causing difficulty in breathing. So we do surgical drainage. The most common cause of perforation of cartilaginous part of nasal septum is, what is the most common cause? That is our trauma, right? Trauma. Now bony septal perforation occurs in, it occurs in what? It occurs in bony septal perforation in syphilis, right? Okay, now the next question is, the nasal septum perforation occur in all of the following except tuberculosis, yes. Nasal surgery, yes. Syphilis, yes. Allergic rhinitis, no, there is not, right? Okay, the septal perforation is not seen in septal abscess. In septal abscess, perforation can be seen. Leprosy can be seen. Rhinophyma, no. Trauma can be seen. Rhinophyma is simply what? It is what? Due to hydropropy of sebaceous gland of tip of nose, right? It does not involve septum also. The bony nasal septum perforation is characteristically seen in. Bony nasal septal perforation is characteristically seen in. It is seen in what? Wegener's granulomatosis, right? It is seen in Wegener's granulomatosis. Now next question is, maggot in nasal cavity are most commonly treated by, these are treated by what? These are treated by chloroform diluted with water, right? Chloroform diluted with water. Okay, the next question is, the patient present with nasal obstruction after being hit on face from front. On examination, a bogey swelling on the septum is seen on either side. Picture which is fluctuant on palpation with swab and blunt probe. It should be managed by, obviously it should be managed by incision drainage, because it is what? It is what? Septal hematoma, right? So these are all about the question from what? Our septal, what? The disease of nasal septum. Now the MCQs that we'll cover is from the topic of acute and chronic rhinitis. Now without delay, let's begin with the first MCQ. So here the common cold is caused by, right? Common cold is caused by, primarily by, it is caused by virus. Prolonged and repeated use of nasal decongestant will lead to rhinitis medicamentosa, right? Now here what will happen is that constriction of blood vessel in lining of nose, right, causing rebound nasal congestion. Okay, rhinitis medicamentosa is due to, that is due to what? Nasal decongestant. A man using xylometazoline nasal drops continuously for a long period of time what can be the possible adverse effect? Okay, we are sure about it. The same thing, rhinitis medicamentosa. All of the following surgical procedures are used for hypertrophic rhinitis except, right? All of the following surgical procedures are used for hypertrophic rhinitis except. Now here, okay, here radio frequency ablation of inferior turbinate, it can be done, right? It can be done. Laser ablation of inferior turbinate, that can be done, right? Inferior turbinectomy can be done, but submucosal placement of celastic in inferior turbinate, it cannot be done, right? Submucosal placement of submucosal placement of celastic in inferior turbinate, it will what? It will aggravate the condition, right? Okay. Mulberry appearance of nasal turbinates. What is the mulberry appearance of nasal turbinate, right? It is our what? Hypertrophic rhinitis, right? It is hypertrophic rhinitis. Which of the following organism is known to cause atrophic rhinitis, right? Atrophic rhinitis is caused by Klebsiella ogyena, right? Klebsiella ogyena. Okay. The ogyena is also known as, we have already mentioned, it is also known as atrophic rhinitis. All are implicated in etiology of atrophic rhinitis except surgical excision, surgical excessive tissue destruction, granulomatous condition, right? All are the implication in etiology of atrophic rhinitis except, right? Surgical excision of tissue destruction, yes. Granulomatous condition, yes, it is also right. And then DNS, no, it is not right. And strong hereditary factor, that's right. Deviated nasal septum will not what? Is not the etiology of atrophic rhinitis. Atrophic rhinitis. Regarding atrophic rhinitis, which is correct, common in female, yes, it is common in female. Seen in 50 to 60 years of life, no, it is not seen in 50 to 60 years of life, right? Now here this will start at puberty, right? Common in female, right? And it can occur secondary to syphilis, and there will be what? There merciful anosmia, right? Now here this though it is estrogen deficiency has been implicated in the causation of atrophic rhinitis, right? But it is not seen at menopause, right? Here this is the time of menopause, but it is not seen at menopause. It is seen in female with low estrogen at puberty. All are true about ogyena except common in female, that's right, it is usually unilateral. Okay, it is not unilateral, right? It is bilateral. Nasal cavity is filled with crust, that's right. Atrophic pharyngitis, right? Okay, atrophic pharyngitis. Now here ogyena, right? Atrophic rhinitis, here both the nasal cavity are filled with crust. All are true regarding atrophic rhinitis except more common in males, no, that's not right, right? Crust are seen, yes. Anosmia is noticed, yes. Young's operation is useful, yes, right? Okay, the most common cause of obstruction in atrophic rhinitis is, that is excessive formation of what? Crust. The excessive crusting lead to nasal obstruction in spite of what? Roomy cavities, right? Excessive crusting, what it will do? It will cause what? Obstruction instead of what? In spite of roomy cavities. Alkaline Dowd solution of nose does not contain. Now alkaline Dowd solution of nose, what it contains? It contains of sodium biborate, sodium bicarbonate, and sodium chloride, right? Sodium chloride. So sodium chloride is there, sodium bicarbonate, sodium biborate. So what is not present there? The thing that is not present there is glucose, right? Glucose is not present there. Okay. Now Young's operation is done for, it is done for atrophic rhinitis. We know about it, right? The allergic rhinitis, nasal mucosa is in allergic condition, right? In allergic condition, the nasal mucosa is, right? It is not congested, right? In congested in the case of inflammation, so it is pale. But pale, it will be swollen, or in pale it will be atrophied, right? Here it will be pale and swollen, right? In allergic rhinitis, the mucosa, nasal mucosa and anterior rhinoscopy appear pale and boggy, right? That is swollen and sometimes bluish also. Congested and swollen appearance is seen in infective rhinitis, right? Not allergic infective rhinitis. Also in vasomotor rhinitis and what? Sinusitis, right? That is inflammatory conditions. Talking about pale and atrophied mucosa is seen in the case of atrophic rhinitis, right? Atopic rhinitis. Okay, allergic rhinitis treatment include all except mast cell stabilizer, yes, that's right, avoiding allergen, right? Okay, corticosteroid, that is also right, but surgery it is not done here. Vedian neurotomy is done in the case of vasomotor rhinitis, right? Okay, moving to our next question, which is treatment of rhinitis medicamentosa? Okay, it is withdrawing of nasal drop with short course of steroid. That is the right answer. Which of the following drug, right? Which of the following drug is linked with rhinitis medicamentosa? Here, the drug that is linked with rhinitis medicamentosa is, what is it? It is what? Decongestant. What is decongestant? Here, xylometazoline, right? Nasal decongestant, xylometazoline, right? Okay. Now, feature of atopic rhinitis include watery nose? No. Yes, merciful anosmia. Swelling of turbinate? No. Swelling of over the dorsum of nose? No. So anosmia is the right answer. True about vasomotor rhinitis is, it is type of allergic reaction? No, it is not. Clinically, it simulates allergic nasal allergy? That's right. Right? Nasal mucosa generally congested and hypertrophic. Right? Nasal mucosa will be generally what? Congested. It will be congested and there will be hypertrophy. Hypertrophy of inferior turbinate is commonly present. That's right. Oral nasal decongestant are used in treatment. That's also right. Right? So what are true? It simulates nasal allergy. Nasal mucosa is generally congested and hypertrophic. Hypertrophy of inferior turbinate is commonly present and oral nasal decongestant are used in treatment, right? So these are about what? These things. Now moving to our next question, the management of rhinitis medicamentosa is, what is the management of rhinitis medicamentosa? This is what? This is our local steroids. Now the patient present with nasal obstruction in anosmia, right? The nasal endoscopy picture is seen below. The following constitute the treatment except there is nasal obstruction and anosmia. So here what? Obviously, now here which of the following are treatment except, that means which is not the treatment, right? It is the case of what? Atopic rhinitis, right? Nasal douching, yes, it is done where? In sodium bicarbonate, sodium biborate and NaCl, right? Inferior turbinectomy, inferior turbinectomy is done here. No, it is not done here, right? Young's operation, yes. Glucose in glycerin solution, yes, it is also done. So inferior turbinectomy is not done here. So these are all about the questions of what? Questions of our which portion? Question of acute and chronic rhinitis. Now the topic from which we are going to solve MCQ is from sinusitis of ENT. Right? Now without delay, let's move into the discussion. Now here the first question is, right, the first question is the sinusitis. In sinusitis, the sinus most involved in children is, now here the sinus which is most involved in children, that is our ethmoid sinus, right? Ethmoid sinus. Now the maxillary sinus develops earlier to ethmoid sinus, right? Right, these both ethmoid and maxillary, they are present at the birth, right? Since ethmoid is more well pneumatized sinus at birth, this is most commonly affected sinus in infant and young children. But maxillary sinus is what? It is the most common sinusitis in adult, right? And talking about sphenoid sinusitis, it is the least involved, right? Least common. The most common organism causing acute sinusitis. What is the most organism causing acute sinusitis? That is Streptococcus pneumoniae, right? Streptococcus pneumoniae is the most common organism causing sinusitis, right? Okay, now here talking about what? The other Streptococcus pneumoniae is the most common, along with Haemophilus influenzae is also the causative organism, right? Streptococcus group A, right? In virus, rhinovirus, influenza virus, parainfluenza virus will also cause it, right? But the most common is Streptococcus pneumoniae. Common organism causing acute sinusitis. I have already said Streptococcus pneumoniae is the most common, along with it, right? Haemophilus influenza, right? But Moraxella catarrhae will also cause it, right? Okay. Now moving further, symptom of sinusitis are all except. Now talking about the symptom of sinusitis, right? Rhinorrhea, yes, there will be rhinorrhea. Headache will be there, yes. Nasal blockage, yes. Diplopia, no. Diplopia will not be there, right? Now diplopia will be there in the case it will if the sinusitis will undergo complication, right, in orbital complication. Periodicity is characteristics feature in which sinus infection, right. Talking about periodicity, what is periodicity? Periodicity, or we can say what, office headache, right. Periodicity, it means headache over forehead that comes up while walking, gradually increases and reaches peak at the midday and then subside by late afternoon. That is office headache, right. And these headache over the forehead that increases on walking and reaches peak at the reaches peak on the midday and then subside by late afternoon. That is what, that is the characteristic feature of frontal sinus infection, right, frontal sinusitis, right. Okay, now talking about the sphenoid sinusitis, pain is referred most commonly to. Now talking about sphenoid sinusitis, now where is the pain referred? The pain is referred to occiput, right. Pain is referred to occiput, right, occiput or vertex, right. Pain is referred to occiput or vertex. Similarly, right, okay, the pathogenomic feature of chronic maxillary sinusitis is mucus pus in middle meatus. Okay, that is the pathognomonic sign, right, pathognomonic sign of chronic maxillary sinusitis. All sinuses are seen in which type of view? Okay, all are seen in lateral view, but here, okay, here in lateral view all sinuses are seen, but here the answer that we do take here is Waters view, but in Waters view posterior ethmoidal sinus are not seen, right, posterior ethmoidal sinus are not seen. Caldwell view is done for, now Caldwell view is done for our frontal sinus, it is done for frontal sinus. Now we're talking about these sinuses, right, while talking about these sinuses I'd like to mention in detail about other also, right, such as Waters view, right, Waters view, right. Now Waters view, it is done to visualize every sinuses, but here the one important sinus that is seen maximum in Waters view is maxillary sinus, right, maxillary sinus, it is used for maxillary sinus. And talking about, right, now modified opening mouth in Waters view, that is PIERRES, Pierce view, right, Pierce view is seen in the case of sphenoid sinus, right. Similarly, talking about Caldwell's view, now Caldwell's view is used for frontal sinus. Similarly, lateral view, right, lateral view is the view in which all sinuses are seen including posterior ethmoidal, but here it is mainly used for ethmoidal, right, ethmoidal sinuses. Okay, now best view for evaluating frontal sinus, I have already said, that is Caldwell view, right, that is Caldwell view. Now moving to our next question, that is question number 11. Now in 11, most definitive diagnosis of sinusitis is, what is the most definitive diagnosis of sinusitis? Is it X-ray PNS, nasal endoscopy, transillumination test, proof puncture? So here it is nasal endoscopy. Nasal endoscopy is what? The definite diagnostic of sinusitis, right? A 35-year-old male presented with history of nasal discharge, facial pain, fever which did not subside with few course of antibiotic and antihistaminic for 3 months. His symptom has aggravated on endoscopic mucopurulent discharge from middle meatus, right? Okay, and inflamed sinus opening. Investigation of the choices. Now what is the investigation of choice right here? Now the investigation of choice is NCCT-PNS, right? NCCT-PNS. Okay, that is the investigation of choice. Now which of the following is most common etiological agent, right? Agent in paranasal sinus? Mycosis. Now here it is talking about mycosis, right? Fungal cause. What is the most common fungal cause? That is Aspergillus species, right? Aspergillus species. The most common etiologic agent in paranasal sinus mycosis is Aspergillus fumigatus, right? Fumigatus. All of the following are diagnostic criteria of allergic fungal sinusitis except heterogeneous opacity on CT scan. Yes, is it right? That is seen. Okay, now here, yes, it is seen. Orbital invasion, no, it is not peculiarly seen, right? Orbital infusion leading to proptosis is a feature of what? Invasive aspergillosis, right? Okay, invasive aspergillosis. Now here talking about allergic eosinophilic mucin, yes, it is seen. Type 1 hypersensitivity, it is seen. So which is not the diagnostic criteria of allergic fungal sinusitis, that is heterogeneous, that is orbital invasion. Which among the following is true regarding fungal sinusitis? Surgery is required for the treatment, that's right. Most common organism Aspergillus sinus, no, we said Aspergillus fumigatus, right? So it is not right. Amphotericin B is used for invasive fungal sinusitis, yes, that is right, amphotericin B. Homogeneous appearance and density with heterogeneous radiopaque density, that's also right. And seen only in immunodeficient condition, that's not right. So here the right answer is surgery is the mainstay of treatment. Amphotericin B is used for invasive fungal sinusitis and homogeneous appear on NCCT with heterogeneous radiopaque what densities, right? Now allergic fungal sinusitis will occur where? It will occur in the case of what? It will occur in the case of our immunocompetent right? Immunocompetent patient, right? Competent patient, right? It will occur, okay, it will not occur in immunocompetent, it will occur in immunocompromised patient, right? Okay, invasive fungal sinusitis is seen in what? It is seen in what? Immunodeficient condition. Most common of them being diabetes mellitus, right? Diabetes mellitus. So here this is the broad term we'll use here. Type 1 diabetes mellitus patient present with nasal septum and palate perforation, right, with brownish black mark discharge. Probably the diagnosis is, since here it is what? A black nasal discharge, right? Black nasal discharge, we say it mucormycosis, right? The 60-year-old Chandu is diabetic and presented with black folly-spilling discharge from nose, right? Now examination reveals black discoloration of inferior turbinate. Diagnosis is same thing, that is mucormycosis. The best surgical treatment for chronic maxillary sinusitis is, what is the best surgical treatment? Okay, what is the best? It is, we know that the best treatment is our FACE, functional endoscopic sinus surgery, right? In patient of chronic sinusitis not responding to medical management, the treatment of choice is FACE, right? Okay. Now this Caldwell lock operation and antral was, right? Antral was, these are no longer done for treatment of chronic maxillary sinusitis. And talking about this organs operation, right, is a combination of Caldwell lock and external ethmoidectomy, right? Now it has become obsolete, it is not used nowadays. Okay, FACE means functional endoscopic sinus surgery, right? Functional endoscopic sinus surgery. Okay, sinusitis, the most common complication is, now in sinusitis the most common complication, what is the most common complication? Orbital cellulitis, right? The orbital cellulitis is the most common complication, right? Okay, now orbital cellulitis most commonly occur after which sinus infection? Okay, talking about orbital cellulitis, it commonly occurs after which sinusitis? It occurs mainly after ethmoidal sinus infection, right? Ethmoidal sinusitis. Now moving further, complication of sinus disease includes orbital cellulitis, yes, in ethmoidal sinusitis. Cavernous sinus thrombosis, yes, it is also seen, right? It is also seen. Now talking about cavernous sinus thrombosis, it is intracranial complication, right? Okay. Now superior orbital fissure syndrome, yes, it is what? Orbital complication. Orbital complication includes what? Preseptal cellulitis, right? And then orbital cellulitis, subperiosteal abscess, then orbital abscess. Two cellulitis, right? One is preseptal cellulitis, orbital cellulitis, preseptal, orbital cellulitis, and two abscess, subperiosteal abscess and orbital abscess, right? Orbital abscess. So the complication of acute, so here the answer is all, right? Answer is all. Now moving further, what we have next question is complication of acute sinusitis is orbital cellulitis, right? Potts-Puffy tumor, that's also right? Conjunctival chemosis, yes. Subdural abscess, yes, right? Subdural abscess, extradural abscess, meningitis, brain abscess, cavernous sinus thrombosis, these are intracranial complication. So all of the above are our complication. The patient with sinus infection develop acute onset bilateral conjunctival chemosis, right? Bilateral proptosis and fever. The diagnosis goes in favor of what? Okay, here the patient with sinus infection develops acute onset of bilateral conjunctival chemosis, bilateral proptosis, right, and fever. The diagnosis goes in the favor of, here it goes in the favor of cavernous sinus thrombosis, right? Fever along with acute onset bilateral ocular manifestation points toward cavernous sinus thrombosis. And talking about lateral sinus thrombosis, presents with fever, jugular vein tenderness, and edema of mastoid, right? Edema of mastoid, that is Grissinger sign, right? In patient with onset CSOM, right? That is lateral sinus thrombosis is what? Lateral sinus thrombosis is it is the complication of what? Suppurative otitis media, right? Suppurative otitis media, chronic otitis media. That is the complication of that, in which the patient present with what? Edema in mastoid, that is edema in mastoid, Grissinger signs, tenderness, right? Fever, jugular vein tenderness. Okay. The infection within right cavernous sinus resulting in following sign accept. Okay. Now, okay, infection within right cavernous sinus resulting in following sign accept. Constricted pupil in response to light. It is not the right answer. Why? Because in cavernous sinus thrombosis, pupils are dilated and fixed due to involvement of third cranial nerve and stimulation of sympathetic plexus. Right? There will be not constriction, there will be dilation. Right? And engorgement of retinal vein will be there. Ptosis of right eyelid will be there. Right ophthalmoplegia will be there. Right? Okay. Now, talking about next question, that is question number 27. The young female with long history of sinusitis, right, presents frequent episode of fever, headache, recent onset along personality change. Fundus examination reveals papilloedema, right? The most likely diagnosis is, okay, now here what is going on here? Okay, here, right, there are the feature like fever, headache, right? Personality change is there, and fundus examination reveals papilloedema. The most likely diagnosis is here. The most likely diagnosis is our frontal lobe abscess, right? Frontal lobe abscess. Long history of sinusitis and personality changes. Fundus showing papilloedema favors diagnosis of frontal lobe abscess, right? Okay. Unilateral proptosis and bilateral sixth nerve palsy is seen in. Unilateral proptosis and bilateral sixth nerve palsy is seen in what? It is seen in our cavernous sinus thrombosis, right? Cavernous sinus thrombosis. In patient of cavernous sinus thrombosis, right? Now here there will be what? There will be involvement of sixth nerve, right? Bilateral proptosis will soon follow after unilateral one, right? Okay. In meningitis and hydrocephalus there will be no proptosis, right? No proptosis. Angular vein infection may cause thrombosis of angular vein infection, right? Where it will cause? It will cause infection of cavernous sinus, right? Angular vein, these are from medial, these will arise from what? Medial angle of eye, continuous as facial vein which go deep, right? Deep facial vein communicates with cavernous sinus through pterygoid plexus of vein. That's why it will cause what? It will cause infection, cause thrombosis of what? Cavernous sinus, right? A 2-year-old child with long history of purulent nasal discharge now presents with fever and right-sided conjunctival congestion and edema for past 3 days, right? His fever is 103, WC count is this much, right? 12,000. The culture of eye discharge was negative. X-ray shows opacification of ethmoid sinus. Which of the following should be next step in evaluating the patient, right? So here, right, what we can do, the next step that we can do here is we can do what? CT scan, right? CT scan. The child has probably developed what? Orbital cellulitis, right, or orbital abscess following the ethmoidal sinusitis, for which CT scan should be done. CT scan will differentiate orbital cellulitis from orbital abscess and helps to see the extent of involvement of sinus, right? In the case of orbital cellulitis, right, in the case of orbital cellulitis, after initial stabilization, what we will do? We will go with antibiotic. Phase should be performed later for chronic sinusitis. But in the case of orbital abscess, there will be requirement of antibiotic along with orbital decompression and phase, right? Mucocele is commonly seen in which sinus, right? Mucocele is commonly seen in frontal sinus, right? Frontal sinus. Now, pneumatocele, aerosol is most commonly seen in, that is same, that is our what? Frontal sinus, right? Okay, next question, which of the following is very first step in functional endoscopic sinus surgery? Now, what is the first step? Okay, the first step is uncinectomy, right? Uncinectomy is the first step. Okay, infundibulotomy is done for, infundibulotomy is done for what? For approaching middle meatus, right? Infundibulectomy is done while approaching middle meatus. Indication of face is, okay, inverted papilloma, no it is not. So in indication of face, it is what? Nasal allergy polyposis, mucocele, chronic maxillary sinusitis, right? So these are chronic maxillary sinusitis, mucocele, nasal allergic polyposis. These are the indication of face. Endoscopic surgery is used for the following. Okay, we've already said about it, right? Inverted papilloma we don't use here, right? Orbital abscess, yes. Nasal polyposis, yes. Orbital nerve decompression, no, right? CSF rhinorrhea repair, yes, it is also the right answer, right? Okay, so the right answer are B, C and E, right? Inverted papilloma, it is what? Benign but locally invasive tumor, hence here a white excision is done by lateral rhinotomy approach. Maxillectomy in chronic maxillectomy in chronic carcinoma maxilla is done by open Weber Ferrugin's incision approach, right? So it is not done here. Endoscopic nasal surgery is indicated in, it is indicated where? It is indicated in chronic sinusitis and epistaxis both, right? The endoscopic intranasal approach is used for assessing all except. Endoscopic intranasal approach is used for assessing all except. It is used for lacrimal sac. Pituitary, yes, can be used. Optic nerve, yes, it is not used for assessing cerebellum. Complication of sphenoid sinus surgery are all except. CSF leaf can be there, yes, it can be there. Lateral rectus palsy, it can be there. Orbital emphysema, yes, no, it cannot be there, right? Optic nerve injury, it can be there. So the right answer is orbital emphysema. Now orbital complication will follow maxillary, ethmoid and frontal surgeries due to close proximity, right? Okay, endoscopic nasal surgery is not done in. Now, okay, endoscopic nasal surgery is not done in. Optic nerve compression, is it done? It is done, right? CSF rhinorrhea, it is done. Dacrocystic carcinoma, it is not done. And ethmoidal polyp, it is done. So the answer is dacrocystic carcinoma. To reduce synechia formation after nasal surgery, which of the following packing is mostly useful? That is mitomycin C, right? Mitomycin C is anti-neoplastic agent with anti-fibroblastic activity. It is used to decrease chance of adhesion and fibrosis following surgery. In Caldwell lock operation, the nasoantral window is made through, right? In Caldwell lock operation, the nasoantral window is made through. Now where is it made through? It is made through inferior, right, meatus, right? Nasoantral window, right, inferior meatus. Now moving into next question. The next question is Caldwell lock approach open. We have already said, right, what it will open. Caldwell lock view was good for frontal sinus, but Caldwell lock approach opens our which sinus? Maxillary sinus, right? Okay, commonest complication of Caldwell lock operation is, what is the commonest complication? The commonest complication is our infraorbital nerve injury, right? Caldwell lock operation, infraorbital nerve injury. Lynch Howard surgery is for, it is for our sinonasal tumor. It is for sinonasal tumor, right? Frontal osteomas can be excised by Lynch Howard surgery, right? So it is what? Used for sinonasal tumor. Antral puncture is done through inferior meatus, right? It is done through inferior meatus. Antral puncture. Proof puncture is done through, it is done for maxillary sinus, right? Antral puncture through inferior meatus and true puncture through what? Maxillary sinus, right? During maxillary was, sudden death is due to what? During maxillary was, the sudden death is due to ear embolism, right? It is due to ear embolism. 49-year-old diabetic patient present with black necrotic mass filling the nasal cavity and diplopia of affected site. Management should be, what is the management? Since black necrotic mass is there, what we can suspect? The person is suffering from what? Our mucormycosis, right? Mucormycosis. So the treatment of choice is IV amphotericin B with orbital exenteration, right? Which one of the following is false regarding chronic maxillary sinusitis? Now, false, right? Normal X-ray effectively exclude hypertrophic mucosa. Is it true? Okay, talking about this point, right? Yes, it is true. Normal X-ray effectively exclude hypertrophic mucosa. Face is indicated for failure of medical treatment or presence of sinonasal polyp, right? It is also true, right? It is also true. Patient complain of postnasal discharge. It is also seen. Headache is absent except during exacerbation of acute sinusitis. So it is not right, right? Headache is absent except during exacerbation of acute sinusitis. It is not the right statement. Right? There is headache. Most feared complication of face is, what is the most feared complication of our face? That is internal carotid injury, right? Internal carotid injury is the most feared complication. Now moving further, face is not done for. Is it done for chronic maxillary sinusitis? Yes, it is done. Blown out fracture? No, it is not done. Ethmoidal polyp, it is done. Allergic fungal sinusitis, it is done. So blown out fracture is the right answer, right? Knob supplying angle of mandible. Now what will supply the angle of mandible? It will supply it by greater auricular nerve, right? Greater auricular nerve. True about allergic fungal sinusitis are all accept. True about allergic sinusitis are all accept. Fungal hyphae are present in allergic mucin, which is pathologic landmark, right? It is right. Invasion of sinus mucosa with fungus, it might not be right. Allergic reaction to fungus, yes, it is right. Surgical clearance is ministry of treatment, yes, it is. So invasion of sinus with fungus is not the right answer. Cardwell lock operation, the approach is through, it is through opening maxillary antrum, right? Now how we are going to open maxillary antrum? Through inferior orbital rim, through sphenopalatine recess, through gingivolabial sulcus, through superior meatus. So here what we do is we do it by opening maxillary antrum through gingivolabial sulcus by sublabial approach, right? Opening maxillary antrum through gingivolabial sulcus by sublabial approach, right? Okay, the agent is used to prevent synechia after nasal surgery, that is mitomycin. What is Potts tumor, right? What is, sorry, Potts-Puffy tumor, right? Potts-Puffy tumor. It is osteomyelitis of frontal bone causing what? Subperiosteal abscess, right? It is what? Osteomyelitis of frontal bone causing subperiosteal abscess, right? That is Potts-Puffy, right? We can remember F, right? Osteomyelitis of frontal bone causing subperiosteal abscess. Okay, treatment of choice for nasal synechia is the same thing, topical mitomycin, right? Okay, moving further, most common cause of fungal sinusitis, we have already said Aspergillus fumigatus, right? It is the most common cause. Okay, now of a 45-year-old male with a history of nasal blockage 6 months, right? For 6 months on examination, the patient has nasal mass with mucin discharge. What is the probable diagnosis based on CT scan? Now here what we can see is, we can see nasal maxillary sinus is filled, right? Here nasal cavity is also filled of left side, right? Okay, so here unilateral obstruction is seen there, fluid level is also somehow seen here. What is the probable diagnosis on CT scan? Since it is what? Unilateral blockage, right? It is what it is. What is the what? It can be enteroconal polyp, right? But here we know that enteroconal polyp were what? Seen in young individuals. So here, but the here presentation is 45-year-old. So here it is, the right answer is allergic fungal sinusitis, right? The here the NCCT, right? So the haziness of left maxillary sinus. right? Haziness of left maxillary sinus, right? And mass in left nasal cavity also, in nasal cavity also, in maxillary sinus also, right? Without any bony erosion, right? So it is what it is, allergic fungal sinusitis, right? Okay, now moving further, right? 35-year-old male presented with nasal discharge, facial pain, nasal discharge is there, right? Facial pain is there, fever is there, which persisted with several courses of antibiotic and antihistaminic over the period of 3 months. On nasal endoscopy, mucopurulent discharge from middle meatus and inflamed sinus opening is seen. His NCCT nose and PNS is given below. He should be best managed by. Now, what we can see here is this is all filled, right? This is all filled, right? Since there is what? Now here, as you can see, the left side of maxillary sinus is what? There is complete what? Haziness here, right? And also we can see nasal cavity of both sides is what? There is haziness, right? Nasal cavity also there is haziness. In left maxillary sinus also there is haziness. So here what we can do is, the treatment of choice that can be done here is FACE, functional endoscopic sinus surgery can be done. So this, okay, now talking about the next question, that is which view of X-ray is shown here, right? Okay, since what here the view of X-ray is our Waters view, right? Type 1 diabetic patient present with fever, left-sided facial edema, periorbital edema, diplopia, antibiotic breath. On examination, there is necrotic area on upper lip, right? In upper lip, there is necrotic area. There is black necrotic mass in nasal cavity. See the patient below. Random blood sugar is 450 mg per deciliter, right? Ketones were detected on urine examination. This should be managed by. Now here, this should be managed by what? Since there is black necrotic mass, right? So it might be the case of what? Mucormycosis. So what we can do here is we can do local debridement and intravenous amphotericin B can be given here. Okay, moving toward the next question. The next question is which surgery is shown below, right? Here this is what? This is Cadwell lock operation, right? Cadwell lock operation. Okay, now we know that in Cadwell lock operation we reach maxillary sinus through what? Sublabial approach, right? Through gingival-labial approach. 35-year-old presented with nasal polyp and mucinous nasal discharge. Here CT scan is given. Here the radiological sign is. Okay, now 35-year-old with nasal polyp, right? We can see the polyp right here, right? And mucinous nasal discharge. CT scan is given with the radiological sign is. What is the radiological signing? As you can see, double density, right? Double density is seen here. The double density is the right answer. POTS, puffy tumor is subperiosteal abscess of frontal sinus, right? Osteomyelitis causing subperiosteal abscess of frontal sinus. So this was all about what? This was all about our questions from what? Sinusitis. Now the topic of discussion that we are going to talk over is we are going to talk about what? The nasal polyp, right? Nasal polyp. Now without delay, let's move into the MCQs of nasal polyp, right? Okay, the first question is which one of the following statement is not correct for ethmoidal polyp? Now before getting into ethmoidal polyp, let's talk about brief about enteroconal polyp and ethmoidal polyp, right? Ethmoidal polyp. Talking about is, right, enteroconal polyp is seen in young individual. These are seen in what? These are seen in older individual, right? These are what? These are infectious in nature, so they are unilateral in presentation. These are what? These are allergic in what? In allergic, so these are bilateral in presentation. These are what? Solitary, right? Solitary and are of large size. These are multiple and of small size. These are some of the basic difference. Now moving into the question, which of the following statement is not correct for ethmoidal polyp? Allergy is the etiologic factor. Yes. Occurred in first decade of life? No. Occurred in later decade of life, right? Are bilateral? Yes. Are associated with bronchial asthma? Yes, that is also right, right? Bronchial asthma, when they are associated with bronchial asthma, that's called Samter's triad, right? Samter's triad, right? It is what? Yes, aspirin intolerance, sinonasal polyp, and what? Our bronchial asthma, right? The most common nasal masses, that is our polyp. Regarding ethmoidal polyp, which one of the following is true? Epistaxis? Okay. No, it is not right. Unilateral? No, it is not right. Less than 10 years? No, it is in older individual associated with bronchial asthma, right? Ethmoidal polyp, true is children? No. Unilateral? No. Solitary? No. Adult? It is true, Recurrent polyposis are seen in recurrence occurs in what? Recurrence polyps are seen in, right, our ethmoidal polyps, since they are what? Allergic in nature. So recurrence will occur what? In them, right? Recurrence is seen in ethmoidal polyp which are allergic in nature. Which of the following best differentiate antroconal polyp from ethmoidal polyp? Right? Okay, antroconal polyp from ethmoidal polyp. Antroconal polyp are multiple? No, they are not. Best seen in posterior rhinoscopy. Okay, they are seen in posterior rhinoscopy. Recurrence in polypectomy? No, they are not recurrence on polypectomy, right? Okay, that is also wrong statement. They are bilateral? No, they are unilateral. So base seen on posterior rhinoscopy is the right answer, because antroconal polyp, they go posteriorly toward choana. In patient with multiple bilateral nasal polyp, right? In patient with multiple bilateral nasal polyp with X-ray showing opacity in paranasal sinus, the treatment consists of all of the following except, right? Treatment consists of all of the following except. That means here it is talking about multiple bilateral nasal polyp, that is ethmoidal polyp, right? Now it will include, treatment will include all except what? Phase, yes. Corticosteroid, yes. Antihistaminic, yes. But amphotericin B is not done here. The clinical description is suggestive of what? Ethmoidal polyp, right? Ethmoidal polyp. Here there is no role of antifungal agent, that is amphotericin B. The patient with ethmoidal polyp undergo polypectomy presents 6 months later with ethmoidal polyp. The correct treatment is, that is our phase. The surgical management of recurrent what ethmoidal polyp is done by phase, right? Okay, Samster tried include, I have already said A, yes, A, that is what? Asthma, right? Sinonasal polyp, right? Asthma, sinonasal polyp, right? Nasal polyp, and aspirin insensitivity. Aspirin intolerance, that is aspirin sensitivity, right? So B, C, and D are the right answer. B, C, D are the right answer. Moving into next question, that is Samster triad is related to. Now where is this Samster triad related to? It is related to ethmoidal polyp. Young syndrome is, what is Young syndrome? Young syndrome is the condition in which there is what? Infertility, right? So here infertility with bronchiectasis is the right answer. All are seen in Carter-Jenner syndrome except. Now before getting into it, what is Carter-Jenner syndrome? Carter-Jenner syndrome is a condition in which, right, there is what? Ciliary dyskinesia, right? There is situs inversus, right? Bronchiectasis, right? Sinusitis. So ciliary dysfunction is present there? Yes. Azoospermia? No. Aspirin sensitivity? No. Situs inversus? Yes. All are seen in Carter-Jenner syndrome except azoospermia and aspirin sensitivity are not seen here, right? So the answer is B and C. Okay. Now moving toward the next question. Bernoulli's theorem explains. What does it explain? It explains, Bernoulli's theorem explains what? Nasal polyp, right? Now how it, okay, thyroglossus cyst and our this laryngomalacia are congenital malformation of oral cavity and pharynx, right? Okay, and talking about Janker's diverticulum, it occurs due to neuromuscular incoordination, right? So here nasal polyp is explained by Bernoulli's theorem, right? Okay, Killian storm is used for which type of polyp? It is used for antroconal polyp, right? Antroconal polyp. Killian polyp is another name for antroconal polyp. Which of the following are true for of antroconal polyp except? Common in young, right? Single and unilateral, right? Bleed untouched? No, polyp do not bleed untouched because they are simply what? They are simply what? Hypertrophied edematous non-neoplastic prolapsed mucosa of nose and paranasal sinus, right? Prolapsed mucosa of nose and paranasal sinus. They don't contain no blood vessels, so they are insensitive and they are what? They do not bleed and touch. Regarding antroconal polyp, which one is true? Origin from maxillary sinus and goes to nasopharynx. Is it right? Okay, that's right, right? Nasopharynx, it will go to choana. Present with severe bleeding? No. Bilateral? No. Seen in elderly person? No. Antroconal polyp, single and grows posteriorly? That's right. Multiple? No. Bleeding? No. Okay, so A is the right answer. Recurrent epistaxis is not common feature of. Recurrent epistaxis is not common feature of DNS. It is common feature of DNS. Rhinosporodiasis? Yes, it is. Nasal polyp? Here there is no recurrent epistaxis, right? Nasal polyp have very poor blood supply, so epistaxis does not occur in nasal polyposis. Okay, next question is, antroconal polyp is characterized by unilateral, usually bilateral? No, it is not. Allergic? No. Arise from maxillary antrum? Yes, it is. Cardwell lock operation is treatment of choice in recurrent case. It was earlier but not nowadays. Recurrence is common? No. So the right answer is derived from maxillary antrum. All of the following are true about antroconal polyp except it is single, that's right. Right? Unilateral, that's right. Premalignant, no. Right? Arise from maxillary antrum, yes. So C is not the right statement. Premalignant. Okay, treatment of recurrent antroconal polyp is, what is the treatment? That is phase, right? Phase nowadays. Before, what Caldwell lock operation was also used. The current treatment of choice for large antroconal polyp in 10-year-old is, a current treatment of choice for large antroconal polyp in 10-year-old child is, obviously we know what? The phase, right? 2-year-old child present with bilateral polypoidal nasal mass. Right, most important investigation prior to undertaking surgery is in 2-year child. What we can do? We can do CECT. Right, in such small nasal polyp are not there, so we have to rule out meningeocele or meningomyelocele. Right, to go for CECT before proceeding further. About foreign body in nose in a child, true is okay. When there will be a foreign body in nose of child, it will have unilateral fetid discharge. Presents with unilateral nasal obstruction, right? Inanimate object is more common than animate object, right? So these are the right statement, right? These are the right statement. The most common cause of unilateral mucopurulent rhinodia in children is, that is what? Mucopurulent unilateral, that is foreign body, right? Antroconal polyp, what? It will mainly present with unilateral nasal obstruction, right? If nasal discharge will be there, it will be mucoid, not mucopurulent, right? And talking about angiofibroma, presents with repeated torrential or profuse epistaxis in pubertal male. Talking about rhinosporidiosis, presents with epistaxis and a mulberry nasal mass. A child presented with history of unilateral purulent nasal discharge with occasional bloody discharge from same side. The diagnosis is, there is unilateral purulent nasal discharge, right? With occasional bloody discharge from same side. The diagnosis is, what can be the diagnosis? Obviously, again, the foreign body, right? Okay, now moving toward next question. Topical steroid has no role for sinus surgery in. Now, topical steroid has no role for sinus surgery in what? Our antroconal polyp, right? Antroconal polyp, right? Okay. Moving further, a child with battery as foreign body in nose, which of the following is important concern, right? Local release of chemical from battery and destruction of tissue is the most important concern. All of the following are feature of ethmoidal polyp except common in adult, yes. Commonly singular, no. Bilateral, yes. Usually allergic, yes. So B is the right answer. Which of the following is true about Kellyan's polyp? Common in adult, no. Singular, yes. Commonly bilateral, no. It is usually allergic, no. So singular is the right answer, right? Okay, moving to our next question. True about antroconal polyp is, it starts edema at maxillary sinus mucosa, yes. Steroid drop are beneficial, no, it has, these are not. Grow toward posterior ears, yes. More common in adult, no. Excised by face, yes. So A, C and E are the right answer. Treatment of choice in bilateral ethmoidal polyp is, treatment of choice in bilateral ethmoidal polyp is, that is what? That is our face only. The combination of nasal polyp by bronchial asthma and aspirin sensitivity is referred to as, it is referred to as Samstert, right? We already discussed about it. Post-operative steroid are not used for, these are not used for what? These are not used for, we have already said steroid are not used for what? Antroconal polyp, right? These are not used for antroconal polyp. All are true about antroconal polyp except bleed and touch, no. Insensitive to touch, yes. Probing can be done all around, right? It cannot, yes, it can be done. Pale in appearance, yes. So the right answer is bleed and touch, right? They do not bleed and touch. Now the next question is, the next question that we have got is, a 2-year-old child present with bilateral nasal polyp, right? The child is young, right? Here you are talking about child and there is bilateral nasal polyp. He should be investigated for, mucobiscidosis, right? Mucobiscidosis. He should be investigated for mucobiscidosis. Okay. Now, a 35-year-old male presented with nasal obstruction, right? His nasal endoscopy finding of one nostril is given, right, of no inertial. Which of the following is true about the condition? With nasal obstruction, and there is endoscopic finding of 1, right? So here it is talking about what? Enteroconal polyp. So the right answer is what? No, it is not. Do not bleed. Best managed by intranasal polypectomy with snare. No, it is not. So Cadwell lock operation is treatment of choice. No, it originates from maxillary sinus and goes to nasopharynx. That's the right answer. Now here, a 20-year-old male present with nasal obstruction and nasal discharge. Nasal endoscopy shows large polyp in right nostril extending into nasopharynx. Right here, you can see what? Now here, what we can see is this maxillary sinus is all gone. Nasal obstruction is there. Right, nasal endoscopy, so large polyp on right nostril. Right, in right nostril we can see the large polyp, right, extending into nasopharynx. Right, into nasopharynx. His CCT and PNS axial view given below. He should be managed by, we know he is managed by what? Face. So these are all about the MCQs from nasal polyposis. Now we are going to solve the MCQs from granulomatous condition of nose. Now without delay, the first question is rhinoscleroma is caused by, it is caused by Klebsiella, right? The complete name is Klebsiella rhinoscleromatis, right? It is also called Fritz bacilli, right? It is also called Fritz bacilli. Okay, now Mcqs and Russell bodies are characteristics feature of. Mcqs and Russell body are characteristics feature of, it is the feature of same, that is rhinoscleroma, right? Talking about the Mcqs or form cells, right? Mcqs or the form cells, these are what? These are large form cells with central nucleus and vacuolated cytoplasm containing causative bacilli. And Russell or hyaline, right? Hyaline body, these are degenerated plasma of plasma cells with large round eosinophilic material, right? Okay, now moving further, the atrophic dry nasal mucosa, extensive crustaceans with woody hard external nose is suggestive of. Okay, now here it is talking about what? Woody hard nose, right? It is talking about woody hard nose, right? The crusting is what? Extensive. So here it is what? Rhinoscleroma, right? Rhinoscleroma, right? Woody hard nose is diagnosis of rhinoscleroma. Okay, the other thing about it is right, it has got this our rhinoscleroma or respiratory scleroma. It has got how many? It has got 4 stages, right? 4 stages. The one is catarrhal stage, right? One is catarrhal stage, another is atrophic stage, another is our nodular or granulomatous stage, and another is cicatricial stage, right? Cicatricial stage. Okay, now here, now talking about catarrhal stage, right? It is here, it is really foul purulent nasal discharge, that is here it is called Carpenter's glue, right? Atrophic stage, here the crusting or nasal stenosed nasal cavity is seen, right? And we know that contrast, we know that roomy nasal cavity is seen in the case of atrophic rhinitis, right? Similarly, in nodular or granulomatous stage, Mcqs or Russell's cells are seen, right? And Hebra nose, right? Hebra nose, that is woody nose, is also seen here. And cicatricial stage, here tapir nose, right? Addition and stenosis of nares, coarse and distorted external nose, that is tapir nose, is seen here. So these are the characteristics of what? Our rhinoscleroma. All of the following are true about rhinoscleroma except biopsy is diagnostic. Now here the biopsy is the diagnosis because Mcqs and Russell bodies are seen. Causative organism can be cultured. Now here the causative organism, yes, it can be cultured, occurs in endemic area. It occurs, yes, in endemic area, right? Okay, it occurs in endemic area. Medical management is done. Here medical management is what? It is not done. So here medical management is done, but what? Right, medical management is done. Yes, medical management is done here. That is, we provide streptomycin, right? Rifampicin, tetracycline, right? Medical management. Surgical intervention is the treatment of choice. So it is not the treatment of choice. The treatment of choice is our medical only, right? Radiotherapy and surgery can be done, but medical we try to do it through medical ways only. So the answer is option number E. Sorry, the except option number E, all other are the answer, right? All of the following are true about rhinoscleroma except, right? Okay, that is the E is the answer, right? Other all are the correct statement. Now about nasal syphilis, true is perforation occurs in septum. Okay, now talking about the perforation, there is one perforation in septum that is done by our syphilis. One is the cartilaginous, right? In cartilaginous portion there is perforation that is done by leprosy, right? But whole there will be, I mean whole septum and cartilaginous portion, there is what perforation in both, that is done by our what Wegener's granulomatosis, right? Perforation occur in septum, that's right. Saddle nose deformity may occur. Yes, there may be depression of what the dorsum of nose, right? The newborn, it is present as snowfalls. Yes. Atrophic rhinitis is a complication. Yes, that is right. And talking about secondary syphilis, is the commonest association? No. So option number A to D are all the right answer. Apple jelly nodules on nasal vestibule are found in, these are found where? In lupus vulgaris, right? Rhinosporidiosis is caused by, right? Rhinoscleroma was caused by Klebsiella rhinoscleromatis. But talking about rhinosporidiosis, right? Rhinosporidiosis, it is caused by what? It is caused by Rhinosporidium severi, that is a protozoan, right? Rhinosporidium severi, that is a protozoan. Rhinosporidiosis is caused by, I have already said, it is a protozoan, right? Aquatic protozoan, right? Okay, the true statement about rhinosporidiosis is, right? Rhinosporidiosis is, now sporodiosis, it is commonly caused by Klebsiella rhinoscleromatis, right? It is not caused by it, right? Seen in immunocompromised patient. Okay, now it is seen in immunocompromised patient. Yeah, that's right. Present as nasal polyp, right? It is not seen in immunocompromised patient. It doesn't present as polyp. Can be diagnosed by identification on biopsy. So the true statement is, it can be diagnosed by what? Identification on biopsy. That is the true statement. Okay, now moving further, that is our question number 10. And which of the following is not feature of rhinosporidiosis? Now talking about rhinosporidiosis, the what are the common feature, right? Here there will be what? There will be epistaxis will be there in rhinosporidiosis. Epistaxis will be there. There will be nose block, right? There will be what? Nasal discharge will be there, right? There will be the nasal mass will be there. Nasal mass will be there. Nasal mass will be papillomatous, polypoid, granular, right? Bleed and touch, right? Pedunculated, right? White dot will be there, that will provide strawberry appearance, right? Okay, now bleeding on polypoidal mass, yes, we have said the bleed and touch, right? Polypoidal mass will be there, yes. Russell bodies are seen. Russell bodies are feature of rhinoscleroma, right? Not sporodiosis, right? So it is not the feature, we know. Oral dapsone is useful in treatment. Yes, dapsone is given in the treatment, right? Dapsone is given. Along with dapsone is given, right? It will mature, it will arrest the maturation of spores, right? Inhibit folic acid synthesis, right? And we give 100 mg OD orally, right? Along with it we give iron, vitamin, right? Okay, it is used. Excision with knife is treatment. Okay, now here surgery, right? In surgery, okay, excision with knife is done, right? With knife is done, right? Now so here the correct answer is, all are the correct answer except option number B. The bleeding nasal polypoidal mass with subcutaneous nodules on skin are seen in. Now here that there is bleeding nasal polypoidal mass, right? Bleeding nasal polypoidal mass. From this only we are clear that it is what? Rhinosporidiosis, and it is, there is also with what? Subcutaneous nodules on skin, right? Subcutaneous nodules on skin are also seen. Okay, now moving further, ideal treatment of rhinosporidiosis is what? The ideal treatment is our, what is the ideal treatment? Excision with cautery at base, right? Excision with cautery at base. So the ideal treatment, what we do is we do excise with cautery at the base. While doing it, it is surgical management. At least 2 point blood is kept ready. General anesthesia with orotracheal intubation, and 2% cytokine can be given, right? Now mass is removed. Its base is cauterized, right? Okay, in rhinosporidiosis the following is true. Fungal granuloma, okay, fungal granuloma, no, it is not true. Grace mass, no, it is not true. Surgery is the treatment. Okay, yes, that's right, right? Surgery is the treatment, right? Now strawberry appearance of nasal mucosa is seen in, it is seen in what? It is seen in our rhinosporidiosis, right? Sporodiosis. Okay, strawberry appearance of nasal mucosa is seen in what nasal mucosa in strawberry appearance. Okay, now here we just did mistake, that is strawberry appearance is seen in sarcoidosis. Appearance is seen in sarcoidosis, whereas strawberry mass is seen in the case of our what? Mass is seen in the case of our rhinosporidiosis, right? Mass in rhinosporidiosis. True about T-cell lymphoma is presents with nasal obstruction and epistaxis. That's right. Associated with Epstein-Barr virus. That's right. Cell expressed T cell marker. That's right. Wide local excision is treatment of choice. That's not right. And local invasive is the right. That is what? That is our T cell lymphoma. All of the following are cause of perforation of only cartilaginous part of nasal septum except, right? Tuberculosis, lupus, leprosis, syphilis. So the syphilis will cause what? It will cause the perforation of what? Septal part also, right? Septal part also, not just cartilaginous part, right? Now, Fritz bacilli is the causative agent of, we have already said Fritz bacilli is what? It is our rhinoscleroma, right? Fritz bacilli. Okay, feature of granulomatosis with polyangiitis, right? Granulomatosis with polyangiitis is nasal polyp, no. Perforated nasal septum, that's right. Persistent sinusitis, that's right. Crusting of nasal mucosa and collapse of nasal bridge, these are also right. Collapse of nasal bridge, nasal mucosa, sinusitis and nasal septum, these are the right statement. Now, which of the following statement is true regarding the disease depicted here? Now here, now here what we can see here is here it is talking about what? Here it is talking about what? Our Russell and our what? Our Russell and our what? Mcqs form cells, right? So it is the condition of what? It is the condition of rhinoscleroma, right? Rhinoscleroma. Now here, which are the true statement regarding the disease depicted here, right? The true statement are, right, the histopathology shows foamy macrophages with intracytoplasmic bacilli and plasma cells with Russell body. This is the this is the true statement, right? It is granulomatous with polyangiitis. It is not, right? It is okay. This is the right statement. Now talking about it is granulomatous with polyangiitis, it is not right statement. It is the caused by gram positive bacilli. No, it is also not right. We know Russell. We know what these are. What these were caused by our Fritz bacilli, right? Fritz bacilli. Nasal obstruction is the common complaint. Nasal obstruction is the common complaint, right? Nasal obstruction is the common complaint, right? Okay. Streptomycin and tetracycline for 4 to 6 weeks are used. That's also right? Streptomycin, tetracycline, along with rifampicin are also used, right? So here the answer is the right answer statement are our 1, right, 4 and 5. So the option 1, 4 and 5 is the right answer. Now here you can see 30-year-old male present with right-sided nasal obstruction and recurrent epistaxis. Examination reveals mulberry mass. Okay, mulberry mass. If you remember, where was our mulberry mass, right? With white dot on right nostril. The following is true about the disease, right? Now here it is what? It is our strawberry mass or mulberry mass here, right? What you can say is it is what? It is our rhinosporidiosis, right? Rhinosporidiosis, right? Here you can see it, and it should be managed by excision with cautery at the base, right? It is caused by fungus rhinosporidium. No, it is caused by protozoan rhinosporidium. Biopsy shows Mcqs. No, that is in rhinoscleroma. And rifampicin is given here. No, here the medical management is dapsone, right? Dapsone. So these are all about the questions from what? Our granulomatous condition of nose. Now the MCQs that we are going to do is from the topic epistaxis. Now without delay, let's begin our discussion from first question, that is the commonest site of epistaxis in young, and that is our Little's area, right? Little's area. The Little's area is situated in nasal cavity, where it is situated in anterior inferior septum, right? Anterior inferior septum. The main vascular supply of Little's area is all except septal branch of superior labial artery, Yes, septal branch of superior labial artery, which is the branch of facial nerve, facial artery, which is further the branch of external carotid artery, right? Okay, now septal branch of sphenopalatine artery. Is it the branch of sphenopalatine artery? Okay, no, it is not the branch. Okay, it is a branch of sphenopalatine artery. Septal branch of sphenopalatine artery will also do it. Anterior ethmoidal artery, yes. Palatal branch of sphenopalatine. Palatal branch of sphenopalatine is what? It is not the supply vascular supply, right? And greater palatine, it is the supply, right? Greater palatine is the main supply, that is a branch of maxillary artery. So here the right answer is option number D. Kesselbach plexus is found by all except greater palatine artery, yes. Septal branch of sphenopalatine artery, okay, it is, yes. Septal branch of sphenopalatine artery. Posterior ethmoidal artery, no, it is not, right? Septal branch of superior labial artery, yes. Inferior ethmoidal artery, yes. So answer is option number C. Kesselbach plexus formed by septal branch of all except posterior ethmoidal artery. It will not form by posterior ethmoidal artery. Which artery does not contribute to Little's area? We all know posterior ethmoidal artery. Commonest cause of nose bleeding is trauma to little ear, Little's area, yes, trauma to Little's area. Cause of epistaxis are all except allergic rhinitis, tumor, foreign body, hypertension. We know it is not allergic rhinitis, right? Allergic rhinitis is present with paroxysmal episode of sneezing, itching, rhinorrhea, P&D, postnasal drip, and not with epistaxis. Commonest cause of epistaxis in children is, what is the most commonest cause? It is what? Trauma. Trauma is the most common cause of epistaxis in children and young, right? That is done by nose pricking, right? Now, talking about foreign body, the most commonest cause of unilateral what? Our foul smelling nasal discharge, right? Not epistaxis, foul smelling nasal discharge. Okay, moving to our next question, that is the most common cause of bleeding in children is, okay, we already said what is the most common? Trauma, that is nose picking. The most common cause of epistaxis in 3-year-old child is, what is it in 3-year-old child? Okay, now here it is our upper respiratory cataract, right? Upper respiratory cataract lead to dryness, crusting, and irritation, which on removal by nose pricking lead to epistaxis. The 5-year-old child cause unilateral epistaxis is what? It is because of what? It is because of foreign body, but trauma is the better option, which is not here. Recurrent epistaxis in 15-year-old female, the probable cause is female. Here it is talking about female, so juvenile nasopharyngeal fibroma cannot be the answer. So here the right answer is our hematological disorder, right? Epistaxis in elderly patient person is commonly due to, it is due to what? It is due to our which condition? It is due to hypertension, right? Hypertension. 70-year-old patient with epistaxis, on examination BP is 200 by 100 mm of Hg, no active nasal bleeding noted. Next step of management is, what we can do next step? The next step is we can observe with BP management, right? BP is so high, we can observe with BP management. Commonest site of bleeding is, what is the commonest site? That is what? Little's area along with Woodrop's plexus. What is Woodrop's plexus? It is present in lateral wall, right? Behind middle turbinate and inferior turbinate, and it is the site for posterior epistaxis, as Little's area is the site for anterior epistaxis. Woodrop plexus is seen in what? I've already said posterior. What? It is seen in posterior part of what? Inferior what? Turbinate, right? Posterior part of inferior turbinate. Source of epistaxis after ligation of external carotid arteries. We know external carotid artery has what? Branches: facial artery, maxillary artery. Maxillary artery has what? Greater palatine and sphenopalatine. And facial have what? Sublabial, right? Sublabial. So after external carotid ligation, maxillary artery will be there? No. Greater palatine? No. Superior labial artery? No. Ethmoidal artery will be the source of what? Source of bleeding. Similarly, if the posterior epistaxis cannot be controlled, which artery is ligated? Okay, if posterior epistaxis cannot be controlled, which can be ligated? That is sphenopalatine artery can be ligated. Sphenopalatine artery is the artery of epistaxis because it is present in what? Anterior epistaxis also and posterior epistaxis also, right? Okay, in case of uncontrolled epistaxis, ligation of internal maxillary artery is to be done in, right? Internal maxillary artery ligation should be done what? Should be done where? In pterygopalatine fossa, right, in pterygopalatine fossa. In case of uncontrolled epistaxis, ligation of internal maxillary artery is done in the pterygopalatine fossa. Treatment of choice in recurrent epistaxis in patient with hereditary hemorrhage and telangiectasis is treatment of choice for recurrent epistaxis in patient with hereditary hemorrhagic telangiectasis is what? Our septal dermoplasty, right? Septal dermoplasty. Posterior epistaxis true is controlled by posterior nasal packing, yes, and another is it is seen in hypertensive, right, elderly individuals. Location of Woodruff's plexus is, I've already said, posterior end of what? Inferior turbinate, right? Inferior turbinate. The artery which lead to bleeding in posterior epistaxis is sphenopalatine artery, right? Present in both anterior in Little's and Kisselbeck's plexus. Kisselbeck plexus is situated in. It is situated in where it is situated in. It is situated in anterior inferior part of nasal septum, right? That is Little's area, right? Okay, Woodruff's area is situated in posterior end of inferior turbinate, right? It is repeated many times. All of the following are true about nasal myiasis except, right? Except, okay, common in vasometorrhinitis, no, it is not right. Intense nasal irrigation present, yes. Caused by maggots, yes. Chloroform water is one of the mode of treatment, yes. So answer is common in vasometorrhinitis. Now here a 7-year-old child presents with unilateral nasal obstruction with folly smearing nasal discharge. The diagnosis is, here the diagnosis is foreign body, right? All of the following are feature of nasal foreign body except, right? Except it is what? Folly smearing discharge is present there, yes. Epistaxis, yes. Nasal obstruction, yes. Sagging of the nose is not seen there. Endoscopic sphenopalatine artery ligation is done in. Where it is done? It is done in the case of severe epistaxis, right? Which of the following is true regarding anterior epistaxis? Patient is kept in sitting position and slight leaning forward position while compressing the nares. That's right, right? That is okay. That is right. Topical phenylephrine is contraindicated as it increases blood pressure. No, that is not right, right? Okay. Talking about commonly formed Kisselbeck's venous plexus in anterior septum. Commonly, yes, it is right. Foliage nasal tamponade is treatment option. No, it is not right. So A and C are the right answer. The artery of epistaxis is, I have already said, sphenopalatine artery. Now the following device is used for the management of, as you can see what is going on here. Okay, if you'll see, okay, now here what we can do is, I think here what we are, okay, here the, okay, here, right, it is what is going on here. Here it is, we are doing what? The picture shows posterior nasal packing, right? So it is showing posterior nasal packing. So here with balloon tamponade it is doing posterior nasal packing. So here it is, the management is done in the case of posterior epistaxis. So this was all about the questions from what? Okay, questions. Okay, there are again remaining questions. The given picture shows, what is this? This is our what? What is this? This is here, what is going on here? Here Hippocrates technique is being done, right? That is Trotter's method, is the first step of management of epistaxis, right? What is this? This is Hippocrates technique, right? Or Trotter's method in first step of management of epistaxis. The vessels marked in the arrow is, what is this? This is sphenopalatine artery, the artery of epistaxis, right? Okay, now moving further, the circle area, what is this circle area? We know what is the circle area, Kisselbeck plexus, right? Kisselbeck plexus. The injury to the area lead to orbital hematoma. Injury to which artery lead to orbital hematoma, right? We know that is anterior ethmoidal, right? Okay, which of the following artery is never ligated to control epistaxis? We know that is internal carotid is never ligated, right? Okay, this was all about MCQs from the topic of epistaxis. The topic from which we are going to cover MCQ is from our fracture of face and CSF rhinorrhea, right? From fracture of face and CSF rhinorrhea. Now, without delay, let's move into our first MCQ. Now, here it is the most important primary care in faciommaxillary trauma is, okay, the most important primary care in faciommaxillary trauma, okay, it is always A, B, C in order. That means airway. That means we ensure adequate airway. Right, we ensure adequate airway. The most common fracture bone in face is, what is the most common fracture bone in face? Okay, it is our what? It is nasal bone. Now talking about the fracture, okay, now what is the second, right? What is the second most second most common fracture of bone? That is our what? That is our zygoma. right? Zygomatic bone is the second most fractured bone, facial bone, right? It is also called quadruped, right? Loss of what? Malar eminence, right? Okay. Now nasal fracture is the most common fracture of what? Most common fracture in face, right? Okay, talking about nasal fracture consists of two types. They are jar-jaw fracture, right? And another is G-valid, right? G-valid fracture. Okay, now moving to our next question. The ideal time of correction of fracture of nose is, what is the ideal time for correction of fracture of nose? Okay, it is, the ideal time is our after 1 week, right? After 1 week. Where? Okay, after 1 week. Okay, simply what will happen is that simple fracture without depression is what? There is no treatment for simple fracture without displacement. But if there is displaced fracture, then if there is early presentation, no edema is there, then we can do close reduction directly. But in late presentation, right, if edema is there, then we wait for what? We wait for 1 week, about 5 to 7 days, and then we do what? We do reduction. Vertical and horizontal fracture of nasal septum are called vertical. That means it is our nasals, okay, it is our nose, right? The vertical fracture is what? It is the horizontal fracture, and it is the vertical. The vertical fracture is, what is the vertical fracture? The vertical fracture is chivulate, right? From chin, right? From chin, it is just, we're just punching from chin downward. That is chivulate, and the horizontal is jar-jaw fracture, right? Jar-jaw fracture. Okay, now going further, the jar-jaw fracture of nasal septum, the fracture line is, now how is the what fracture line of jar-jaw fracture of nasal septum? We have already said jar-jaw is a horizontal fracture, right? Now here what will be the fracture line, right? Obviously it will be what? It will be horizontal only, right? In chivulate fracture of nasal septum, the mechanism of trauma is, we have already said, from chin region, from below, right? From below. While playing football, an 18-year-old boy was hit on nose and developed deviation of nose. On examination, septum was not deviated, right? The following about the patient is true, right? Okay. Now here he should be taken off for open reduction 1 week later, right? He should be taken for closed reduction as soon as overlying edema subside. Septoplasty should be done in the same setting. He is having jar-jaw fracture. Okay, here it is saying that and developed deviation of the nose. On examination, septum was not deviated. The following is true about the patient. True, right? Okay. Now he should be what? He should be taken for close reduction as soon as the overlying edema subside, right? There should be edema subsiding. There should be subsiding. Edema should be subsided before what? Close reduction. Nasal bone fracture is corrected by, now how is the nasal bone fracture corrected, right? There are two forceps. There are Balram forceps and another is Mcqs forceps, right? So Balram forceps is used, right? Balram forceps is used, right? Now talking about the Lux forceps, it is used for septoplasty and Cadwell lock operation. Citilis forceps, right? It is used for punching out hole in bone or other tissue. Right? And Tillis forceps is used for dressing in ESC and doing anterior nasal packing in epistaxis, right? Okay, Balsam's forceps, right? It is what it is. What it will do is it will lift non-depressed, right, bone laterally with what? The non-depressed bone is lifted laterally with Balsam's forceps, right? Now here it is what? This Balsam forceps is straight, right? And talking about our Mcqs forceps, it is what? It is angulated, right? Angulated. These both are used where? In what? In correcting what? Nasal bone fracture. Okay, tripod fracture is seen in. Now what is tripod fracture, right? Okay, talking about tripod fracture, what is it? It is our zygoma, right? Tripod, or also what we have said, it is what? It is our quadruped, right? Tripod or quadruped. It is the second most common what? Fracture of nasal bone, right? Okay, now fracture zygoma solve all the feature except, now fracture zygoma, talking about the clinical feature, right? What will happen? Okay, now here this fracture zygoma, right? Zygomatic bone fracture, right? Zygomatic bone fracture, it will show all of the above, right? It will show diplopia. Yes, it will show diplopia, right? It will show, no, it will not show CSF rhinorrhea. Enophthalmos will be shown, trismus will be shown, right? Along with it, right, there will be periorbital emphysema due to escape of air from maxillary sinus. There will be restriction in what? Eye muscles, right? Oblique palpebral facial due to displacement of lateral palpebral ligament. Trismus is seen there, right? Okay, but there is no what? There is no what? our CSF, right? CSF rhinorrhea is not seen, enophthalmos is seen. Okay, moving to our next question. The next question is, the fracture zygoma show all of the following except cheek swelling. It will show cheek swelling, it will show trismus, nose bleeding, right? Okay, now here it will show what? It will show our it will show what? It will show trismus. It will show trismus. It will show intraorbital anesthesia, diplopia, but it will not show cheek swelling and nose bleeding, right? Cheek swelling and nose bleeding will not show. Along with it, what? Along with trismus, intraorbital anesthesia, right? And our diplopia also. Now along with it, what other features are also seen, like enophthalmos, right? Enophthalmos, but here cheek swelling and nose bleeding are not seen. Epistaxis is not seen here. The patient presents with what? The patient presents with enophthalmos after a trauma to face by blunt object. The diagnosis is, okay, enophthalmos after a trauma to face by blunt object. The diagnosis is, yes, I have said enophthalmos is seen where? It is seen in zygoma, right? Tripod fracture or quadripod fracture, right? So it is seen in fracture of zygoma. Teardrop sign is seen in, okay. Now teardrop sign is a feature of CSF rhinorrhea, right? It is seen where? It is seen in fracture of what? Okay, teardrop sign is seen in fracture of floor of orbit, right? It is seen in the fracture of floor of orbit, right? Okay, blown out fracture. Talking about the blown out fracture refer to what? Blown out fracture refer to fracture of what? It is what? It is blown out fracture refer to fracture of what? Orbital floor, right? Orbital floor. Now because of this orbital fracture of orbital floor, there will be what? There will be teardrop sign, right? Teardrop sign in Waters' view shows a convex opacity bulging into antrum from above, that is teardrop opacity, right? Okay, the nerve damage in zygomatic fracture is, now what will be damaged in zygomatic fracture? Obviously it is what? It is intraorbital nerve, right? Intraorbital nerve is fractured in zygomatic fracture. Lefort classification is for fracture involving which bone? Okay, Lefort fracture, that is fracture of Mcqs, right? Mcqs. Lefort fracture type 1, right? Type 2, type 3 are present, right? Talking about type 1, what? Type 1, that is what? Here there will be what? There will be fracture. Where will be the fracture? Fracture will be above a nasal floor through nasal septum, maxillary sinus and inferior part of pterygoid plate. And talking about 2, it is also called pyramidal fracture, right? Here it will run obliquely from maxillary sinus to floor of infraorbital margin across orbital floor and lacrimal bone to nasion. Lefort 3, it is what? It is Lefort 3 runs medial orbit wall to superior orbital fissure, right, across sphenoid and zygomatic bone to zygomatic frontal suture and inferior to pterygoid plate, right? Now Lefort fracture does not involve what? Okay, as I have already said, the Lefort fracture, right? Lefort fracture, it is the fracture of maxilla, right? Maxilla, obviously maxilla is included, right? Along with it, there will be what? There will be involvement of what? There will be involvement of zygoma also, right? Nasal bone also, but mandible is not involved. Craniofacial dislocation is seen in, now craniofacial dislocation, right? Dissociation, sorry. Craniofacial dislocation is seen where? It is seen in type 3, right? Type 3 fracture, craniofacial dislocation, right? That is also our what? In Lefort 3, pig snout deformity is also seen, right? Now here type 3, it runs from what? From medial orbital wall to superior orbital fissure, from medial orbital wall to superior orbital fissure across sphenoid and zygomatic bone to zygomatico-frontal suture and inferiorly to pterygoid plate, right? This is Lefort 3 fracture, right? Craniofacial dissection is seen here. Most common site for fracture of mandible. What is the most common site for fracture of mandible, right? Okay, now fracture of mandible, the most common site is our subcondylar, right? In mandible, right? In mandible, the most common site for fracture is subcondylar, right? Guardsman fracture involves. The guardsman fracture involves symphysis with condyles. It involves symphysis with condyle, right? Okay. CSF rhinorrhea occur most commonly due to fracture of what? A fracture of cribriform plate, right? It occurs because of fracture of cribriform plate, right? Now talking about CSF rhinorrhea, right? CSF rhinorrhea, there are what? There are, right? There are common, there are what? Different what? Fractures, right? Fracture site, like in anterior cranial fossa, right? In anterior cranial fossa, cribriform plate is what? The main site, right? Main site for CSF rhinorrhea. Similarly, in medial cranial fossa, sphenoid sinus is the main site, right? Talking about posterior cranial fossa, there is what? This is also sphenoid sinus, right? And here along with it, right? What? From mastoid cell, or from inner middle ear, there will be what? A fracture of temporal bone in, and from there eustachian tube will be connected, and from nose there will be what? There will be discharge, right? That will be CSF otorhinorrhea. Okay, now here CSF rhinorrhea most commonly occur due to fracture of cribriform plate, right? Cribriform plate. Now moving to our next question, the most common site of leak of CSF rhinorrhea is, what is the most common site of leak of CSF rhinorrhea? Okay, it is, we have already said cribriform plate, right? Cribriform plate is the most common site, but cribriform plate is the part of ethmoid bone, so ethmoid bone is the right answer. The most common cause of traumatic CSF rhinorrhea is obviously the same thing, what? Ethmoidal sinus, right? CSF rhinorrhea is seen in, where it is seen, we know, right? We have already said it is what? Mainly seen, it is in relation to ethmoid, so it is mainly seen in nasoorbital ethmoid fracture. Spontaneous CSF rhinorrhea is associated with all except, right? Okay, spontaneous, that means it is non-traumatic, right? Non-traumatic CSF rhinorrhea is associated with all except transverse fracture of temporal bone, partial or complete empty sella syndrome, pseudotumor cerebri, encephalocele, right? Okay, it is right. Okay, now this spontaneous CSF rhinorrhea is associated with what? It is associated with partial or complete empty sella torsica, sella syndrome, right? Pseudotumor cerebri, encephalocele. But transverse fracture of temporal bone, as here there is what? There is fracture, so here it is what? It is traumatic condition, not non-traumatic condition. So transverse fracture temporal bone is a traumatic cause, right? It is a traumatic cause, so it is the right answer. CSF rhinorrhea is diagnosed by, okay, talking about CSF rhinorrhea, it is diagnosed by beta 2 what? Beta 2 transferrin, right? Beta 2 transferrin. Talking about difference between CSF, okay, talking about diagnosis of CSF rhinorrhea, right? Now nasal discharge biochemistry is very important. Nasal discharge biochemistry, in which glucose level will be what? Glucose level will be more than what? 30 mg%, right? Beta transferrin, there will be detection of beta 2 transferrin, right? And then talking about CT and MRI, right? CT and MRI and brain with contrast can be used. Now localization of site of CSF leakage can be done, right? And similarly CT cysternography with metriamide and ionoxol can be done, right? And similarly fluorescent dye injection plus endoscopy under blue light, right? Fluorescent yellow colored CSF is seen, right? Yellow color. So what are these? These are the diagnoses, right? Here glucose level can be seen, right? Similarly what? Glucose level test can be done, sweet in test, there will be sweetness in test, right? Character watery color will be discharged, beta 2 transferrin will be present here, right? Okay, that is one. Another thing is that sniffing test will be what? Sniffing test will be negative, right? Now the discharge cannot be sniffed back, right? That is negative, right? Okay, those are what? Those are the diagnosis of CSF rhinorrhea. True about CSF rhinorrhea is what? It is seen in fracture of cribriform plate, that's right. It contains glucose, that's right. Contains beta 2 transferrin, that's right. Required immediate surgery. Okay, talking about requires immediate surgery, here in this condition we don't require what? Okay, here it is asking about true statement, right? Okay, so A is true, right? A is true, B is true, C is true, right? Okay, now halo sign is what? It is present, not absent, right? Halo sign, what is halo sign? Okay, target sign, double target sign, or what? Double what? Our ring sign, right? CSF when mixed with blood produces peripheral CSF halo, right? CSF halo with a central what? With central blood and filter paper or pillow cover, right? That is present in the case of what? In the case of CSF rhinorrhea. Along with halo sign, handkerchief sign, right? Handkerchief sign, right? Handkerchief sign is also present, positive here, right? Okay, similarly what are other sign, right? These are the sign, reservoir sign or teapot sign, it is also present here, right? Teapot sign is also present here. Okay, Now all of the following statement about CSF leak are true except commonest site of CSF leak is lateral lamellae of cribriform plate. Okay, beta 2 transferring estimation is highly specific for diagnosis. Yes, fluorescent dye can be used intrathecally for diagnosis of site of leakage. It can be done, right? MRI gadolinium canker T1 image are best for diagnosis of site of active lesion. So here MRI is not used, right? Instead CT is stenography, right? Similarly intrathecal fluorescent dye are used, so it is not used, or the all are used. So here this is the right answer. A young male is brought to hospital after road traffic accident. Patient is stable but clear water like fluid coming out from nose. Management of choices, obviously what is going on here? Here CSF rhinorrhea is going on, right? So what is the treatment of choice? Now here the treatment of CSF rhinorrhea is conservative, right? Right? Okay, now what we do in conservative treatment, we provide we say them to have bed rest, right? We avoid coughing, right? Sneezing, nose blowing, any strenuous activities, right? Antitussive, right? Antitussive are what? For dry persistent cough, antitussive can be given, and laxative can be given for what? Laxative for constipation, because here we can't bear patient straining, right? So we can do these things. Similarly acetazolamide, furosemide can be given. Repeated removal of CSF through repeated lumbar or indwelling lumbar subarachnoid drain can be done, right? Okay, that can be done. And in drainage, in medication, acetazolamide and furosemide we are giving it because they decrease CSF production. So halo sign and handkerchief sign are positive in, I've already said these are positive in CSF rhinorrhea, right? Okay, moving to our next question, that is intrathecal fluorescence with endoscopic visualization are useful in diagnosis of intrathecal fluorescence with endoscopic visualization. We have already said by injecting by dye injecting plus endoscopic under blue light, fluorescent yellow colored CSF will be seen, right? That is done in the case of CSF rhinorrhea. Pathogenomic test for CSF is suspected CSF rhinorrhea is, we know that is beta 2 what? Transferrin. Intraorbital nerve is injured commonly in, now where it is injured? Intraorbital. Okay, that is mainly where? Intraorbital nerve, that is a blown out fracture of orbit, right? Blown out fracture of orbit, that is usually at what? Below what? Orbital floor. The head injury, patient is conscious, right? In head injury, patient is conscious, CT is showing fractures, CSF leakage through right nostril. The management is okay. CT is showing fracture and CSF leakage is there. Now the management is how we are going to manage. Head low position, wait for 2 weeks for spontaneous stoppage of leakage, immediate stenography and transcranial operation to close the defect, endoscopically close the leakage. So what we do here is we wait for 2 weeks for spontaneous stoppage of the leakage, right? We wait for 2 weeks. Now in CSF rhinorrhea, CSF from medial cranial fossa reaches the nose via, right? From medial cranial fossa, as I have already mentioned before, right? From medial cranial fossa, it is what? It is sphenoid. From anterior cranial fossa, it is what? It is our what? Cribriform plate. But in medial and posterior cranial fossa, it is sphenoid sinus. Okay, 25-year-old player got hit on nose, right, and developed deviation of nose. As you can see, there is deviation, right? It should be managed by, it should be taken up for open reduction 1 week later. It should be taken for closed reduction as well as overlying. Yes, we have already said this is the right answer, right? Now moving to our next question, the following instruments are used in which surgery? Okay, here, right, the angulated is our S, right, and here straight one is our what? Waltham forceps. Now it is used for what? Closed reduction of nasal bone fracture, right? Okay, that is closed reduction of nasal bone fracture. Similarly, the following test is done. What is this? This is handkerchief test, right? Handkerchief test. It is done in CSF rhinorrhea. Now similarly, right, okay, the given picture here, what we can see, this is what? This is inside there is what? Red, outside there is what? CSF, right? What is this? This is CSF, what? CSF rhinorrhea. Now here it is what? It is halo sign, right? Target sign is most likely suggestive of, right? Target sign is most likely suggestive of traumatic CSF rhinorrhea, right? Traumatic CSF rhinorrhea. Target sign. Target sign, we know what is target sign. Okay, it is what? It is the side of CSF, traumatic CSF rhinorrhea. Blown-out fracture most commonly involve floor of orbit. We have already said the floor of orbit. The patient, the casualty following injury on face is CT is given below. The most probable diagnosis is right here. What we can see, what is this, right? What is this? This is tear down, right? Tear down. What sign in CT? Now it is seen in blown out fracture. So this was all about what MCQs from MCQs from fracture of face and CSF rhinorrhea. A topic from which we are going to solve MCQ is from tumor of nose and paranasal sinus. Right, now without delay, let's begin our discussion. Okay, the first question is inverted papilloma arise from. Now here inverted papilloma, it is the benign most common tumor of nasal cavity, right? It arises from what? It arises from what? It arises from lateral wall of nose, right? It arises from lateral wall of nose. Now talking something more about inverted papilloma, right? Now it is also called Ringer's tumor, right? It is also called Ringer's, okay, Ringer's tumor. And another thing is, right, it arises from what? It arises from Siderean membrane, right? Siderean membrane that is present in lateral wall, right? Now it is what? How it is treated? It is treated by endoscopic excision, right? It is treated by endoscopic excision. So these are important point, right? Important point. It is benign but cause local bone destruction. So there is high risk of what? Malignancy, right? Okay. Inverted papilloma is characterized by all SA. It is also called Siderean papilloma. It arises from Siderean membrane, so it can be, right? It is seen more in female. Okay, talking about male and female. Male and female ratio is how much? Female is about 5:1. So it is not right, right? It is not right. And present with epistaxis and nasal obstruction. Talking about the clinical feature, patient present with unilateral progressive nasal obstruction, right? And nasal obstruction, we are sure it is there, and epistaxis is rare, right? But usually it is not present, it is rarely present, okay? It can be seen also. Originates from lateral wall of nose. So all things are right except what? Seen more in female. So this is the answer. True about inverted papilloma. Okay, true about inverted. Arise mainly from nasal septum? No, that's lateral wall, Siderean membrane. Common in children? No. Common in 40 to 70 years old individual. Similar risks of malignancy. Okay. Risks of malignancy? Yes, I have already said. Since it has local bone destruction, there is risks of malignancy. Post-operative radiotherapy is useful. Okay, talking about its treatment, right? Okay, post operative radiotherapy, yes, right? Okay, no, it is not used, right? The endoscopic excision is the treatment. It is also known as Siderean papilloma. Yes, so the right answer is C and E. All of the following are true about inverted papilloma except more common in male, that's right. Arise from lateral wall of orbit, that's right. Can cause epistaxis, that's right. Recurrent is in nature even after removal. Okay, now here all of the true are okay. Here it is saying it arises from lateral wall of orbit, not nose. So it is the right answer. It arises from lateral wall of what? Nose, right? Nose. True about inverted papilloma is predisposition in children. No, that's not right. May present with epistaxis, that's right. Recurrent rare. No. Okay, recurrent. What about recurrent? Yes, recurrent is what? Not rare, right? Benign in nature, yes. Arise from lateral wall, that's right. So B, D and E are what? The right answer. The most common site for osteoma. Now what is osteoma? That is most common tumor of PNS, right? And it is mainly in PNS, it is what? It is mainly all of the paranasal sinus. It is mainly seen in what? Frontal sinuses. Okay, frontal sinus is the right answer. Commonest site of alveolar osteoma, right? Alveolar osteoma is seen in. Now the most common site of alveolar osteoma is what? Our frontoethmoidal region. Ground glass appearance of maxillary sinus and CNS is seen in. Okay, now talking about ground glass appearance, right? Okay, the ground glass appearance is seen in maxillary fibrous dysplasia. Where it is seen? It is seen in maxillary fibrous dysplasia, right? Maxillary fibrous dysplasia. Ongren's line that divides maxillary sinus into superior lateral and inferior lateral zone is related to. Now it is related to what? Obviously it is dividing what? Maxillary sinus, so it is related to maxillary what? Carcinoma, right? But here every option are maxillary, but it is used in maxillary carcinoma. Talking about Ogren's line, it is what? It is line that is passing from medial canthus, right? Medial canthus to what? To our angle of mandible, right? Angle of mandible. Now here what we do here is what? It divides into superior lateral and inferior medial zone, and the structures on inferior medial, if there is what? There is spread to inferior medial region, that will be better prognosis, right? Intrastructural growth situated below the plane have better prognosis, and suprastructure, that is superior lateral region, right? Suprastructural growth situated above the plane have poorer prognosis, right? Okay, that is about Ogren's line. Talking about other thing, that is Ogren's classification of maxillary sinus carcinoma is based upon, I've already said, from medial canthus to angle of mandible, right? From medial canthus to angle of mandible. True about tumor of nose and PNS, squamous cell carcinoma is the most common type. Adenocarcinoma can occur. Melanoma is most common. Adenocyst carcinoma is the most common. Esthesioneuroblastoma is the most common. No? Here the most common carcinoma of PNS is squamous cell carcinoma, right? Now another, the people working in hardwood furniture industries, the most common carcinoma is adenocarcinoma, right? Adenocarcinoma. So here adenocarcinoma, right? The woodworker carcinoma, it is called woodworker carcinoma, right? The most common malignancy in maxillary antrum is, okay, what is the most common malignancy in maxillary antrum? So the most common is our what? Squamous cell carcinoma, right? Squamous cell carcinoma. Moving further, the first lymph node involved in maxillary carcinoma. What is the first lymph node? That is submandibular, right? In maxillary carcinoma, the first lymph node involved is submandibular, the commonest lymph node also, and the first lymph node also, right? The woodworker associated sinus carcinoma. What is the woodworker associated sinus carcinoma? I've already said woodworker carcinoma, that is what? That is adenocarcinoma, right? Okay, adenocarcinoma, they are also called woodworkers carcinoma. Going to adenocarcinoma of ethmoid sinus occur commonly in. Now adenocarcinoma of ethmoid sinus occurs more commonly in, that is also the same thing, woodworkers. Early maxillary carcinoma presents as. Now how the early maxillary carcinoma presents as, right? Okay, now here it presents as what? Blood tinged nasal discharge, yes. Supraclavicular lymph node, no, it is not, right? Proptosis, no. Nasal obstruction, okay, nasal obstruction is also the right option. Cheek swelling, no, there is not. So the earlier, right, there will be, how it will be presenting, it will present with what earlier clinical feature? It will mimics maxillary sinusitis, like there will be nasal stiffness, there will be blood stained nasal discharge, right? There will be what other things also, like facial paresthesia or pain, epiphora will be there. Carcinoma maxillary sinus stage 3, right? Carcinoma maxillary sinus stage 3, T3, M0 and N0. Treatment of choice is, so what is the treatment of choice? That is surgery and radiotherapy, right? In stage 3, the treatment of choice is what? Our what? Surgery and radiotherapy. Now here for all patients, now here I would like to make one point, that is in all patients with carcinoma of maxillary sinus except small T1 lesion, the treatment is surgical resection, right, followed by radiation therapy, right? In every surgical with radiotherapy, right? In every except small lesion in what? Small lesion in our T1 stage. So going to our next question, the tumor arising from olfactory nasal mucosa is, tumor arising from olfactory nasal mucosa, right? What is the tumor? The tumor is esthesioneuroblastoma, right? Esthesioneuroblastoma. Okay, the tumor arising from olfactory nasal mucosa, that is esthesioneuroblastoma, right? the mucosal commonly involved. Now, what does this involve commonly? Okay, frontoethmoidal region, right? Frontoethmoidal region. All are malignant tumor of nasal cavity except, okay, what is not the malignant? We have already said Ringer's tumor. That is what? That is our inverted papilloma. That is benign condition, but it has what? Maximum chance of malignancy. Which is not true in fibrous dysplasia. Okay. Now here, benign neoplasm of nasopharyngeal region. That's right. Present in first and second decade of life. That's also right. Right. And classical X-ray finding ground glass appearance. Yes, we did this question. Mandible is commonly affected. No, mandible is not commonly affected. Right. Okay. Now what is this line? Medial canthus to angle of mandible, the upper suprastructure, below infrastructure. The suprastructure has poorer diagnosis, right? And the infrastructure has good diagnosis, right? Good diagnosis. Now this line is what? This is our what? Ongren's line, right? This is our Ongren's line. So this was all about what? This was all about questions from our what? Tumor of nose and paranasal sinuses.